72 people signed up, which tells me this is a subject that a lot of people have a lot of questions about. And I wanted to be able to help people answer those questions, because I am here all day with men and women, and people ask me these questions all the time, and I'm like, I'm not a doctor. But I see you every day, and I know what's going on in your life, and I'm able to kind of help you figure out which doctor you need to see a lot of times, because I had a lot of experience with that. Come on in, come sit down. Also, I've got Juju's Coffee here, if anybody wants to get some coffee, and I've got PDC Kitchens, just Punch Drunk Chef Kitchens here with meal prep food. So if you are interested in meal prep, they got it. And then I've got some.
Yes. Hi, we're doing the job. I think gluten-free. I started this business because my PCOS just developed on me not being able to have gluten, and then I go to the doctor and they said, oh, just eat gluten-free and don't worry about it. It's just regular period cramps when it's not. And then I got a bill of $1,400 for that. So thank you. So yeah, it's just one. I struggle, you know, and then I just want you guys taste it and just let me know what you think.
So she's got some samples out here that are gluten-free if anybody wants to try some gluten-free food. Come on in. Also, a lot of you guys signed up for the DEXA scan, and it will be during the time that people are talking. When it's your time to go, just get up and walk out, which is fine, no big deal. If you are not sure what DEXA scan is, it's amazing. It is a little 7-minute test. You lay in the bed, it scans your body. It tells you your body fat percentage, your visceral fat versus your subcutaneous fat. So visceral fat is the unhealthy fat that is on the organs. Your subcutaneous fat is just this stuff that we just don't like. It's not pretty, but it's not super, super dangerous, okay? So we're not too worried about subcutaneous fat. Visceral fat's a problem. So it really helps you find that out. It also tells you your bone density. And as women, this is a very important number to know, because as we get older, bone density will start to diminish no matter what. Now the truth is that we establish most of our bone density in our teens and 20s. Everything after that is really hard to increase bone density. Does anybody know what the #1 way is for increasing bone density?
Weightlifting.
Weightlifting. Welcome to my haven. Okay, so a little bit about me and CrossFit Odyssey. I started doing CrossFit when I was going through my divorce, and it was not a happy time in my life. And I discovered that by lifting weights and doing all of this stuff, I really developed a lot of confidence. And I got myself out of a bad situation, and I went out on my own, and I was looking for a teaching job while I was teaching CrossFit at another gym, and this literally fell out of the sky and landed in my lap. And I was like, this would be so cool. All I want to do is be able to teach other women how to be strong and confident, and see that confidence in all of them. And it has been my greatest joy to watch some of you come in here, and JJ is my favorite story. JJ was like, I don't want to do a push-up, I'm afraid I'm going to break my nose. And I was like, you're probably not going to. But let's just be careful. And JJ was like, I'm never going to do a pull-up. I'm never going to do heavy lifting. You don't have to worry about that for me. I'm not that kind of person. Well, last year JJ went to the national Olympic meet and came in 7th in the world. JJ no longer apologizes for a lot of things. She just get out of my way. And I'm like, yes ma'am. But that's what we want to see in our daughters. This is what we want to see in our sisters. This is what we want of ourselves. We want that confidence and that power to be who we want to be. Now, the other thing I wanted to remind you guys of, when I started this, I wanted to help all these women. I got like a whole gym of all men. And I was like, where are my clients? So my but I've come to get to know a lot of these men and women, and I've fallen in love with this. Now, I'm gonna fast forward a little bit to COVID, as we get this gym started and everything. All of a sudden, we realized this is not just about looking good naked. This isn't about abs. This isn't about being perceived a certain way. This is about being strong enough to survive the hard things in life. Now, I've got a few people in here who've been through cancer. I've got people who have watched their children die of cancer. I have seen people go through so many things in life. These are real, hard, serious things, and COVID was one of those things for all of us. That's what this is about. We want to be strong enough to survive the hard stuff, right? That's where we're trying to get with this, okay? So I fast forward again. Well, during COVID, I'll tell you, my grandmother died at 103. And I was like, wow, if I die at 103, I still have my whole life I've lived left to live. Like, I was like, that's a long time. And then, fast forward 3 more years, my dad died in 2023, 3 years ago, and he was 76. And he lived longer than anybody else in his family. And I was like, well, if I die at 76, I have 20 years left to live. That, my friends, is the blink of an eye. I have 2 children that are older than that, and 1 that's close. So, if you start thinking about the fact that you have 20 years left to live, you start getting a whole lot more purposeful about how you're going to live it, right? I have things that I want to do, and people that I want to see, and things I want to share and teach with the world to live my most beautiful life. So that is now what this is about. We call this the journey to extraordinary, and that's what that journey to extraordinary looks like for us, okay? So as we come in here and try to get healthy and strong, that's our goal, is to live your most beautiful, extraordinary life you can possibly live with what you have left. So I decided to make sure that I'm going to do that. So living your most beautiful life starts with, number 1, being the healthiest person that you can be to live that life, right? Because I need to be strong enough to do the things that I want to do. So one of the things we talk about is the centenarian decathlon. So if you are in your last decade of life, what things do you want to be able to do during that decade of life? I probably want to be able to go to the bathroom by myself. Most of us want that. It's not something that we look forward to have somebody else wipe our butt, right? So that is a real serious thing. What are the other things you want to be able to do in life? You want to be able to get on the floor and play with your grandkids and get back up. You want to be able to go for a walk if you want to go for a walk. You might want to be able to pick up your suitcase and put it in the overhead compartment, or put your plate in the cabinet. You might want to be able to hang up your heavy jacket in the closet. All of these sound like really small things, but they're things that get really hard to do as you get older. Now, my list is a little crazier than that. I want to be able to go climb Kilimanjaro. So that's what I did last year. So I started making a plan for every year for my birthday. I'm going to do something wild and crazy. So for my 50th birthday, I went and learned how to do a backflip. I was like, what the heck? I might as well learn how to do it. I've never done it in my life. Goals, right? So I started planning something to do every year on my birthday because I want to celebrate the fact that I'm still alive and I can do the stuff that I want to do. So I did a backflip on my 50th. I did 51 steps walking on my hands for 51. For 52, I think I went skydiving. I went Kilimanjaro was 55. Machu Picchu was 56. And I took a whole crew of people from the gym here with me because I was like, no longer am I going to sit and wait and watch people do cool stuff on TV. That's going to be me because I only have this little bit of time left. I want it to be amazing. But my advice to you upon leaving today, and you start making your life what you want it to be, go home and write down all the things that you want to do in this life, because you only get one chance. You only get one chance. Okay, that's your goal for today. So we're going to start with Mary Katherine. So what I'm going to say also is, stronger people are harder to kill. That is one of the things that we have learned around here. And we say it jokingly, but we noticed it with COVID. Stronger people were harder to kill. If you get in a car wreck, stronger people are more likely to survive. When it comes to cancer or any other thing, the stronger you are, the more you fight, the harder you are to kill. And we got some people here who know that. And that's a really important thing to know. And it's not just here that you're strong, it's here. This is very important. This is very important. Know that you have the power within you to survive the hard things that happen, okay? And so I'm going to start today with Dr. Katherine Robertson. She is one of the doctors at Genesis Pelvic Floor Therapy. So I always laugh. People are like, what's a pelvic floor doctor? I'm like, well, there's so much information here, but one of the things that people get the most from this is urinary incontinence. And nobody wants to talk about this. It happens to almost all of us. And I have a drawer in the bathroom full of pads so that when you're doing jump roping, you don't pee yourself. This is a very real issue. And it is, we joke about it, but it's something that people are horribly embarrassed by. I have been horribly embarrassed by, but this can really help you. Now, it also can help with lower back pain. It can help with all kinds of other issues. I've even heard that like foot issues can be solved with pelvic floor therapy. So, very interesting stuff. Here's Katherine.
Elle.
I thought I was going to stand on these, but I'm not.
Elle, give her the microphone.
Hello. Push the little button. Hello. Hello.
I can project. Can you guys hear me? If I start to trail off, just give me like a thumbs up. But I'm Katherine. Like I said, I work for Genesis Physical Therapy, and we have clinics all through the DFW area. I am located at the Dallas location, which is close to Uptown. But I brought my trusty pelvis, and I got lots of looks as I was crossing the street over here or driving by. But I think sometimes it's just really great to see what exactly is your pelvic floor. I know there's been lots of talk about it, but raise your hand if you are familiar with kind of what the pelvic floor is. You got some hands, okay, good. So this is your pelvis. Everything that you can see in red is considered your pelvic floor. So we've got 3 layers of muscles that sit between our sternums and our pelvic bones, and that is what constitutes our pelvic floor. Men have pelvic floors as well. They don't want to admit it, but they do. But I think as women sometimes we are a little more in tune maybe with these muscles. But anyway, the pelvic floor muscles should kind of act like a trampoline. Like they should be able to contract and elevate to provide support, whether it's like shock absorption to prevent you from leaking, or stability when you're moving and exercising, stability when you're lifting something heavy. But we need them to relax. And I think a lot of times we hear so much about how we need a really strong pelvic floor, and I would argue that it's just as important to be able to relax your pelvic floor too. That's going to allow you to move your pelvis to lengthen and rotate and be dynamic and let you jump and all of these things without noticing it, because we want to not notice our pelvic floor, right? We want it to do what it's meant to do without any trouble. So it should operate kind of like in that trampoline, dynamic, automatic, reactive type motion. But then sometimes there are times where we notice that things aren't functioning quite like we want them to. And especially when in kind of like drafting this towards menopause, I'm sure lots of changes come about that you're like, what in the world is going on? Like all of a sudden things just started happening, things feel different. And I think sometimes there's a lot of question marks around like, am I in my head? Why did this happen? Etc. So I kind of wanted to shed some light on that as far as why you may notice changes to your pelvic floor kind of as you're heading into perimenopause or menopause age. So we're going to talk a lot about genitourinary syndrome. less hydrated, tighter, more difficult to move, and so it's not as responsive and as resilient. So you don't get as much of that like dynamic responsiveness that I was mentioning kind of at the beginning. So the hormonal effects to the pelvic floor are a huge reason as to why you start to see things happening. And this happens to nearly half to 2/3 of women going through menopause. So very, very common. I think sometimes, like Elle said, it's embarrassing. No one wants to talk about it.
Nobody wants to talk about it.
No.
Not even me.
It's true. I get patients all the time that are like, this is so embarrassing. I'm like, tell it to me. I'm like, this is not embarrassing. There's no such thing as TMI. So this is a very common thing, and they normally don't resolve on their own, but it can respond really, really well to treatment and just like addressing the issues that are going on. So sometimes there are symptoms that pop up that you may not realize are connected. So when talking about the vaginal area, things like dryness, burning, irritation, tight feeling, pain with intercourse or penetration, whether it's like touching upon or with intercourse, bleeding after intercourse, or even just tightness and tension, can be due to just like estrogen changes in the vaginal area. For the urinary system, things like incontinence, like she had mentioned earlier, whether it's like peeing when you jump or when you sneeze or when you cough, like stress incontinence, or even things just like the urgent incontinence, like I can't make it to the toilet in time, I feel like I start to pee a little bit before I get there or after too, or everything feels really urgent all of a sudden. Burning with urination can also be a symptom. Recurrent UTIs, etc. Those all kind of fall under the umbrella of hormonal changes to the urethra and bladder area. That tissue thins out, so it can be more susceptible to bacteria, less resilience, overactive muscles, etc., which can cause some of the like incontinence type activity. So during that time, when we're seeing less like plumpness to the tissue, less elasticity, less movement, how do you resolve that? Pelvic floor therapy honestly can be a great resource for this. A lot of times, even just a topical estrogen cream can be beneficial if that is something that your OB or gynecologist recommends, just to help add some of that like estrogen back to a localized area. But also pelvic floor therapy can be huge. And what we do is we spend so much time assessing your pelvic floor, and granted, like all these symptoms can present similarly with people, but sometimes the root cause or what's causing it can be different. So we're looking at like, how are these muscles overactive? Are they too tight? Are they underactive and can't provide support? Are they just really like tight and there's not much blood flow to the area? And when that's the cause, we can spend some time working on like mobilizing, bringing more blood flow to the area, helping work on the coordination of those muscles so that they can contract and provide support when they need to, but then they also can relax when they need to as well, just for optimal function. So the way that we go about that is very hands-on. So a lot of manual therapy, whether it's working on the pelvic floor muscles themselves, so working on like an internal release to some of those muscles, bringing blood flow and just awareness of your body to that area. And then also, you notice that all these muscles attached to your pelvis, and what other muscles attached to your pelvis? Your glutes, your hip flexors, hamstrings, inner thighs, core, back. So you've got lots of muscles that attach also to your pelvis, so they're also playing into all of this as well. So when these muscles get tight through your pelvic floor, it's definitely going to affect the surrounding musculature as well. So we'll spend a lot of time not just focusing on the pelvis itself, but how can we treat you holistically to where you're going to be moving better, like the urinary symptoms will resolve, you're able to return back to activity without noticing kind of everything that you have been. So mobilizing the tissue, decrease pain, helping with urinary symptoms, helping with just the tension, and treating accordingly. So we're very manual focused, like I said, but then also exercise and movement is a huge key to this. So I know that there's going to be a lot more on the movement component to come, but that's where we see a lot of the longevity of these results is, as we then how can we make you strong so that your body can actually use that in your activities day to day or in exercise. So
I'm going to ask the question that nobody wants to ask. How do you assess the pelvic floor?
That's a good question. So our assessment is pretty, at Genesis especially, it's pretty lengthy just because the pelvic floor, like she said, can span from like top of your head to your feet. And so we look a lot on like how you move, your posture, your strength, your mobility. That's going to tell us a lot about the pelvic floor without even looking at the pelvic floor muscles themselves. So a lot of just movement screening and looking at strength and mobility. But the internal portion is not as scary as it sounds, but it is a transvaginal assessment. We just do a gloved finger with a little bit of lube, and we're just palpating or like adding pressure, kind of testing the muscles of the pelvic floor. So just with a very not very deep palpation, you can get to those muscles that kind of run on either side of your pelvis, and you can assess for just like how much do they move? Are they really tight? Are they painful? Do they feel very underactive, like not tight enough? And so looking at like tension in that regard, and then we always look at coordination too. So we have you do things like, can you contract your pelvic floor? Can you relax it? What happens when you cough? What happens when you sneeze? What happens when you bear down or push down, like you were lifting something heavy? Do those muscles respond accordingly? And how can we prevent too much pressure down against your pelvic floor to where you're noticing those symptoms that I mentioned earlier? So it's a very quick assessment, but just looking at muscle tension and coordination of the muscles themselves.
How does pelvic floor affect back pain?
Yeah. So if you think about the pelvic floor muscles and say they're locked down and tight and they're not moving, I wish this pelvis moved like a normal pelvis does, but it's screwed together. But basically, you want your pelvis to be able to lengthen and rotate and move side to side. But if your pelvic floor muscles are limiting that movement, you're not going to get as much movement in the surrounding muscles like your glutes, and especially through your low back. If you've got a lot of fascial connections that connect low back, sacrum, tailbone, pelvic floor, then it goes down, dives down to the bottom of your feet. You've got a really long fascial length of your body, and that oftentimes, especially when it's tight in one area, you're going to see a domino effect in other areas too. So the low back especially can be one that takes a big hit on that. Yeah.
How does it affect sciatica?
Sciatica. True sciatica, your sciatic nerve runs from out from your vertebrae, and then it kind of dives down through your mid glute and then all the way down to your foot. So when those glute muscles right here, your deep rotators, get too tight, they're gonna clamp down on that nerve, and then you don't get as much. That nerve can't move, and nerves can get tight just like muscles can. So that's when you start to notice the pain effect of it. It also, a lot of times, it starts in the spine too. If there's irritation, instability, tension at the spine, or it's pinching at where the nerve exits, then you start to notice the effects down the chain as well. Yeah, not very comfortable, but yes.
Should we move the fascia around that one?
So the fascia.
What was the question?
Oh, she said, can you move the fascia around? Is that what you said?
Yeah.
Okay.
Yeah.
Fascia is very nervous system driven, and so fascial release is going to look like providing a sense of safety to the muscles around it. So fascial release can look like a low load stimulus to the muscles in the surrounding area, providing just a sense of safety, promoting blood flow to the area to get it to kind of calm down. But kind of has a little bit of a domino effect, but it's not like a muscle, how you can trigger point release it. You can't quite do that with fascia, but if your nervous system feels safe, if the musculature around it is operating well and you've got good blood flow, that's going to allow the fascia to kind of relax around it. So.
And are all of your treatments exercise based? You also, if you're low on estrogen, you also do hormone replacement?
That's actually a great question. So we just with the oh yes, I'm so sorry. She asked, is our treatment specifically exercise or just exercise, or do we also provide hormone replacement
And a lot of OB-GYNs don't work with insurance.
Yes.
Mine would do a patch, a still patch, but she did some type of progesterone for the testosterone. And I've seen that a lot.
Yes, she was saying that her OB doesn't always want to touch on the full like HRT therapy.
New doctor.
I do think that there are doctors who have very different opinions and emerge from this, and I do think that there's kind of a black box around hormone replacement therapy for a while, and the new research that's coming out is kind of starting to flip the script a little bit to say this could be a really important thing, especially if we get this depleted. So there's a lot of research coming out in the last like year, couple of years that has really started to kind of change the minds of providers, but it kind of depends on who you're seeing as far as like their comfort level. I think a lot of times I see this a lot with my like postpartum breastfeeding patients too, but when you're so low on estrogen, especially down in the vaginal area, you don't have that appointments to the tissue and can like not have like healing or discomfort, especially postpartum, but during menopausal time that can like a localized cream, like an estrogen cream just to that area is not a systemic hormone replacement therapy, which I think the more localized treatment is a little more comfortable for some providers than it is like the systemic HRT like patches. So
And we are gonna talk more about HRT with Dr. Heintges.
yes,
So we will get
that
that.
is more to come.
Do y'all take insurance or is it cash based or how do you?
We are cash based. We don't take insurance ourselves, but we provide you with all the information for all to submit. Yes. Yeah, and I brought pamphlets in my business card that has you can links to our website, ways to schedule, my information. If you have questions, want to shoot me an email. Yes.
Is pelvic floor therapy something like your OB or your derm where you should go even if you don't have symptoms, or like is it the one you wait until you have a
That's a great question. I would always say proactively is fantastic. But I think a lot of people come to us when they start noticing things. But if you are like, I may not have any specific problems or issues that have cropped up yet, but you just want a general assessment, like we can always just do an assessment and evaluation and kind of tell you, get you started on some things, kind of do more education and talk through movement or, assess the pelvic floor and the surrounding tissue. So I think sometimes it's a great way to just be informed and know more about your body and how you can preventatively help before issues start to arise. But I think a lot of our patients have once they start noticing things.
I send people to pelvic floor therapists when they are having a baby, because going before having a baby is a great idea. So you learn before you have all the damage to your pelvis, after you have a baby, and when you hit menopause and you are starting to have issues, and if you have any lower back or hip or pelvic issues. So that's almost all of us, right?
And sometimes that low back and hip pain, the root cause of it can just be.
I'm looking at all my girls who like, my hips hurt.
So how often is it that physical therapists that you refer patients who work on like low back pain understand that, hey, if we're not healed, we're not getting the results we need at this point, you should probably check out your pelvic floor. I feel like that's not like something that crosses in traditional physical therapists.
Yeah.
Even though they work in the same umbrella, there's a lot of pelvic floor therapists within the clinic. No?
Yeah, I actually started
endometriosis and a full hysterectomy, how does that affect pelvic floor?
Yeah. With a hysterectomy, so endometriosis has a lot of like systemic effects too, but once excised and removed, or if there's a hysterectomy involved, which is removing the uterus, that obviously any surgery to the area is going to have an effect on the surrounding muscles, and your body doesn't know the difference between little scopes or it just knows that there's like trauma to the area. So a lot of times you'll get adhesions, tightness, muscle guarding and protecting to the area just because it knows that something happened. And so we always recommend pelvic floor therapy surrounding a surgery like that just to help make sure that all the tissue's like moving well and there's good blood flow and the muscles aren't just like in protective mode all the time, because they're definitely going to try and prevent anything from happening again. So they'll just go into scary protective mode.
Yeah, your body's an amazing thing.
Yeah.
It, you can, so I always tell people when they come in here, every single person's a little bit different in how your body's gonna move. You start as a toddler doing little things, and then for me, I had a bike wreck when I was about 12 years old, and I got 72 stitches in the back of my calf. And I was in a boot for months after that, walking like this. Guess what that did to my hip? All kinds of damage. So I have hip problems to this day that I'm still trying to overcome, which is going to bring me to Amanda. So before I get to that, I want to talk about the whole menopause thing. So I know most of you know this probably. Perimenopause starts somewhere around 10 years before you hit menopause. You will have fluctuations in your hormones. I'm going to let Michelle get to this more, but you'll have fluctuations in your hormones, and you'll have just things that just feel a little bit off. You'll be like, I feel like a little bit out of it today. And who doesn't when we're raising kids? I mean, you got so much stuff going on, and you're trying to do your job and raise the kids and all the other stuff. Everything's crazy anyway. So then you start thinking, am I losing my mind? And then you start noticing that little extra bit of belly fat. And then you start noticing, I am so freaking hot. What is wrong with me? And then you're like, I'm waking up every night to go to the bathroom. And when I sneeze, I pee. And there's all these little things that start to sneak up on you. And you're thinking, man, I'm just having a moment. And then it kind of goes away for a little while, and then it kind of sneaks back on you. And then it kind of goes away for a while, and then it sneaks back on you. And all of a sudden you're like, oh my gosh, I'm in perimenopause. And you didn't even realize for the past 5 years you've been in perimenopause, okay? So menopause is technically defined as the one day that you have gone 1 year without a period. Menopause is 1 day. Everything after that 1 day is called postmenopause. So when you're talking about, so those of you who are there, congratulations, you survived. Now, just because you're in postmenopause doesn't mean everything stops, right? You still have a lot of the symptoms, things get a little weird. You should theoretically level out over time, but it's the peri part that's killing us, right? It's the peri part that we're noticing, and we're trying to figure out what the heck is wrong with us. Now, there's this other thing called just getting old, and that's a real thing too. As you get older, some of this stuff just starts to happen, things start to fall apart, that's gonna happen. But it is definitely worse with women, and it is definitely worse at this time of life, okay? So, as we get into Amanda, so what I do for a living is try to get you guys strong. I'm like, we're gonna focus on deadlifts, we're gonna work on the core, I'm gonna make you build your bone density and the strength around your body so that you can carry yourself and do the things that you like to do in life. Every person like me with the hip issue has something. So when you come in, I'm like, well, I can work on that, we'll see what we can do, but if it's really nagging you, I send you to Amanda. Because Amanda will sit there and focus on this one little thing until she gets it working the way it's supposed to, and I can focus on the bigger picture, okay? That's her job. So next is Amanda with Raise the Barbell Physical Therapy. You're welcome.
I can talk loud enough. I think. Okay. Everyone, I want you to stand up for a second. Okay, great. Now sit back down. Now stand up. Now sit back down. Now stand up. Sit back down. Stand up. Sit back down. One more. Stand up. Sit back down. Now we're ready. Okay, see, now everyone's happy and smiling. See? Okay, great. Before I get started, there is drip coffee and bottled lattes out front if anyone needs to take a little break. There's also the PDC meal. Everyone's like, yes! Everyone's like, bye! And then I don't have to talk to as many people at once. And then there's also food from PDC Meal Prep. They have little samples of their meal prep. Oh, this is great. Let's go!
Hey, wait,
I can wait a second. It's fine.
She is really nervous talking to large groups.
I'm like, oh boy, I'm sweating.
She figured out how to get everybody out of here.
I know. I was like, hey, bye. We'll wait just a sec. Just a sec. Well, okay. So I'm Amanda. I'm with the owner and founder of Raise the Barbell Physical Therapy. I found Ellie and John
On Instagram.
on Instagram, actually. Ellie, I remember I was like, I had just started my business. I was so nervous about like getting out there. And so I kind of was like looking at all the CrossFit gyms in the area, and I went through and I just like followed them all on Instagram. And within 2 hours, Ellie sent me a message. She's like, we need help. And I was like, okay, what do you mean? And that's how I met Ellie. Except the first person I met was actually John. And John just looked at me. I was like, who are you? Okay.
know John. They're like,
You
yeah,
know John.
yeah.
Like, yeah, that makes sense. So it was, that was how I ended up at CrossFit Odyssey, and I walked in one day and never left. So it's been great. I mean, Ellie is one of those people that
I
she.
send her videos from Instagram. I'm like, look at this shoulder blade. It's so awesome.
Do you see the rhomboid?
I call it coach porn.
No, Ellie and John stand for exactly what I want Raise the Barbell to be and what Raise the Barbell should be known for. And so I kind of, like, it's kind of corny, but my goal is to raise the bar on what you get out of a rehab experience. And so a lot of times, and like we kind of touched on it already, like when you go to like outpatient orthopedic physical therapy, a lot of times like you're being seen with more than one person at once. The therapist doesn't have the bandwidth to focus on like just your issue, unfortunately. And again, I've been there, I've worked there, like I left there because I also felt like I was doing a disservice to myself, and I also was doing a disservice to the people that I was working with. And so what we're going to be focusing on today is menopausal joint pain and adhesive capsulitis. So adhesive capsulitis is frozen shoulder. It's one of the most common things that women in between 40 and 60 will be diagnosed with. So I personally had to go and look at when does menopause start. And so just in case you were like a little bit confused about like what the difference between pre-menopause and perimenopause and menopause and post-menopause, like it's a little bit confusing, but it's a big range of things. If anyone wants this PowerPoint, I will send it to you. There's a QR code at the end. And so pre-menopause is about like a little bit like your late 30s, 40s, early 40s. Perimenopause starts around like mid 40s and goes up until who the heck knows. It could be 50s, it could be 49. It's a wide range, and it really depends on
Person.
you. Yeah. And then menopause again, it's one day. This person was 55 when it happened, and then post-menopause is anything after that. And so we're really talking about the age range that people are in when they get frozen shoulders most commonly. And so that's why I have this up here, but this is not actually what I'm talking about today. It just helped me. So we've already talked about estrogen a little bit. We're going to talk about estrogen a little bit more. Turns out it's really important. And so estrogen has anti-inflammatory effects. And so not only does it involve like the health of your reproductive organs, the health of your vagina, everything that Mary Katherine was talking about, it also is it's a systemic hormone that affects everything. And so declining estrogen levels during menopause are said to increase your overall level of inflammation in the body, as well as your cartilage metabolism, as well as your bone and muscle metabolism. And so unfortunately what that means is if your muscles and bones and cartilage aren't as healthy, you get more issues. And so the effect of estrogen too on your ability to, your experience of pain is actually different as your estrogen levels decline. So estrogen actually almost helps you tamp down any sort of pain perception that you have. And so again, you might have pain even without tissue damage. That's a whole nother PowerPoint. But so we don't really understand why, but a lot of times pain can be more intense when you don't have as much estrogen, even if nothing is wrong. And not to say nothing is wrong, because your brain makes pain. Your brain is the thing that causes you to experience a sensation of pain, even if you didn't break your leg. You can still have pain even without tissue damage. And so without estrogen, a lot of times that can feel a little bit more intense.
So sometimes we'll have people who come in and they're like, I had a rotator cuff tear 4 years ago, and then halfway through the year, they're like, my shoulder's killing me. And I'm like, it's the torn rotator cuff. It's just that it's just now hurting because your hormones are changing. And they're like, but I didn't do anything. I'm like, I know.
It doesn't matter.
Sorry.
It doesn't matter. And then there also is an increase, so most people will start to have more effects if they have any sort of osteoarthritis. And so again, not everybody gets arthritis in all of their joints, but if you have any sort of inflammatory process in any of your joints, osteoarthritis or rheumatoid arthritis, any sort of those inflammatory processes, sometimes it can be made worse with declining estrogen. So really, I'm not going to focus so much. There's so many different places menopausal joint pain can be. It can be low back pain, it can be ankle pain, it can be elbow pain. It doesn't really necessarily fall on just one body part, but the focus here, 40% of premenopausal women report muscle and joint pain. So this is anybody that's under 40. Once you get into that perimenopause and postmenopause, that number increases to 57 to 59%. So you can see, even if accounting for all of the other factors. So again, that would be the age of the person, the activity level of the person. That's what these 37 studies looked at. Regardless, so the only thing that was different was their estrogen levels, and there is a huge increase in the amount of pain that people experience at those points in their life. And then another just stat, women in perimenopause have a 1.35 higher risk of muscle and joint pain than premenopausal women. So again, everybody has more pain. Yes?
I associate perimenopause with premenopause. It's premenopausal women, pre-perimenopause?
Yes.
Okay.
Yep. Mm-hmm. So that's before that. So it's pre, then peri, then the day of menopause, and then post. One day. We're just.
I think I went straight to postpartum.
You're like, I skipped it.
I was great, fantastic. I've got hysterectomy in 2018.
So, yeah, hysterectomies, I'll let Michelle address this, but they can force you into menopause.
Well, no, yeah. I had 5 really good years, no issues. Without a period, it was like bliss. And then it hit me.
Okay, now we're gonna get into, so again, this too, we can't forget about lifestyle factors. And so this slide is probably one of my favorite ones, because a lot of people, when they get past a certain age, they're like, oh my God, I'm old, I can't do that. And I'm like, okay, but did you stop doing that because of your age? Or did you stop doing that because you actually can. And so most of the time what happens is women stop jumping. Well, one, women stop jumping because sometimes they're peeing their pants. And so, I mean, that's fair.
Yeah.
But again, if you stop jumping, no matter why, you can't do it anymore. You lose the ability to do it. And so then you try again, and all of a sudden you start getting pains in other spots because your body isn't used to that load. And so unfortunately, yes, we have the lifestyle factors that increases the, I'm so sorry I was yelling after. we have the hormone changes that cause increased pain, but also at this age range is when women, they retire potentially, they start not being as active, they start maybe not doing as much as they were doing before when they were getting ready, going to work every day, they were in more of a routine. And so a lot of times too, the lack of physical activity can also compound the effects that menopause have on a woman's body. And so I could go on for a while on this, but we're gonna move on. So the next, what we're gonna talk about next is adhesive capsulitis. And so this is one of my favorite things to talk about because it is something that it's something that we can address early. And a lot of people just don't know what a frozen shoulder is and what it means. If your shoulder is tight, it does not necessarily mean you have a frozen shoulder. And so what happens is you have a ball and a socket. This is your arm. What happens is every joint, not just the shoulder, every joint has a capsule. And your capsule is essentially like saran wrap, just wrapped around the whole thing. The shoulder is really cool. It's our most mobile joint, which also means it's our most unstable joint, thank you. And so what happens is we have this little area right here. And so our body has kind of built in an extra piece or part of tissue that allows our capsule to kind of stretch as our arm goes up over our head. So it's part of our capsule. It's called the axillary pouch or the inferior fold. Sometimes you'll hear that called. And so what happens in adhesive capsulitis is it is an inflammatory process that starts and it kind of like contracts the entire capsule, including that little bit at the bottom. And so you can this picture isn't great, but you can kind of see that it almost sucks up that inferior capsule, and so you don't have as much ability to move your shoulder when your capsule doesn't let your ball joint go down as you move your arm up. And so that is inherently the problem in a frozen shoulder, is your capsule it's stuck. It cannot move. Now, so what is frozen shoulder? The American Shoulder of Elbow Surgeons don't know. That's essentially what that says. In a whole lot of words, we don't know. We know what it looks like. We know the signs and symptoms. We know how to fix it, kind of. But we actually don't know why it happens. And most of the time, what they're thinking now is because of the population that typically gets a frozen shoulder, women in between 40 and 60, they're thinking there's some sort of hormone, estrogen probably, that causes just an onset of loss of shoulder motion that we don't really quite understand. So primary, we don't really know. We don't. So there's two different types. Sometimes you can just start losing motion in your shoulder, and you're like, well, that's weird. Like, I didn't do anything. When it happened to my mom, she had been carrying Christmas decorations upstairs. She kind of just tweaked her shoulder, just like a normal thing. Like, after that, within weeks, she couldn't lift her arm up above her head. She couldn't reach behind her to fasten her bra. She couldn't sleep.
I see it a lot of times with people reaching in the back seat of the car.
Yep.
This position.
Yep.
And they pull it all the time.
Yep.
It's always that position.
But again, it could be absolutely nothing. It could just start one day. It doesn't mean, just because you didn't do anything doesn't mean you don't get a frozen shoulder, which is why it's really confusing for people. The secondary cause can be post-surgery, post-stroke, post-injury. So now, if you have a shoulder surgery and your shoulder's tight, that doesn't mean you have a frozen shoulder. This is like a process that is very, very like defined by time frames. We don't like, just because you're tight, just because you had surgery, just because you injured your shoulder, it doesn't automatically mean that you have a frozen shoulder. Oh, this is just an MRI of like the little contracted pouch. That's what I put that up there for. It's not super obvious, but who gets it? Women, 40 to 60. I've said that like 4 times, but like
70. I
Yeah.
had it when I was 7.
probably, yeah. Oh, that's right. Sorry. So it's about 2 to 5% of the general population. Men can get it. I've seen a handful of men with frozen shoulders. So again, it looks exactly the same. They stop being able to do things. They all of a sudden can't raise their arm up above their head. Most of the time, the non-dominant hand is affected first. That's not always true, but it usually is. With my mom, she's left-handed. Her right started first. She's also one of the 14% of the time where she got it on both sides. Her right one was getting better, and then her left one froze. And so it took about 18 months for her to actually get all of her motion back. It was absolutely awful. I was in PT school, so at the time I didn't entirely know what to do, but now I do. Also, you're gonna have more. You're like, I can't go back. I remember.
Only technological.
If you are a diabetic, you're gonna be more likely, 20% more likely to have a frozen shoulder. So usually my 2 questions for women who are coming in with the symptoms that I just described, I ask them, are you a diabetic or do you have thyroid issues? Thyroid issues are another one that typically, if you have any sort of thyroid issues, most of the time it's hypothyroidism, but not always, meaning you don't.
Is that because of the inflammation?
Possibly, we don't know. We have no idea. We just know how to fix it. Yeah,
At least she's honest. At least
we
she's
don't
honest.
know. Yeah, nobody knows. Like, we don't really understand like why the thyroid has something to do with the onset of frozen shoulder, and it could be the estrogen affecting the thyroid hormone. We don't know. That's it. Now, how do you know if you have a frozen shoulder? Well, one, you notice pain at rest. This is like the onset. This is where it's like, my shoulder feels like crap and I didn't do anything. Most of the time, the pain that you're gonna feel, and I kind of like, it's usually on the side top. That's usually where people are gonna feel it. They come in and they're like, this hurts all the time. I don't know what I did. Also, I can't reach behind me. I'm like, oh, okay. Most of the time people are gonna seek help because they can't sleep. They're like, I cannot sleep, I feel like a crazy person. Could that be related to the hot flashes at night from estrogen loss? Maybe. But also, their shoulder just feels really bad all the time. Usually, you feel like you are losing shoulder motion. So typically what happens is it's usually your rotations first. Usually it's the motion where you're going to put on a coat. It's usually like, so then what happens is people start putting their coat on the other side first, or on the affected side first. They put that arm in, and then they can get their other arm in. The second one is usually your overhead this way, overhead this way. And the third one is usually your behind the back motion, tucking in your shirt, reaching behind you for your wallet, putting on a belt, putting on your bra. Those are usually the motions that people are gonna say, I can't get dressed. I need to bend over in the shower to wash my hair. I can't reach up and touch my head. I can't reach the back of my neck. I can't put my hair in a ponytail. I can't do my hair at all.
I can't wash my armpit.
Yep, can't wash your armpit. That's another one. Yep, it's just a dirty armpit for a little while. It's all right. You're under the water. It's no problem.
Toilet.
So again, the biggest thing, another huge one is like you can't reach behind you to wipe.
That's
Yeah.
right.
You can't reach behind you. And so you have to use the other hand, and then it's not wiped as well. Well, like, you make it work. Okay. And then what do now, how is frozen shoulder diagnosed? It's not anything else. That's the short answer. Like, typically what happens, and this is a story I hear all the time. Your shoulder really hurts. You can't sleep. You feel crazy. Your arm hurts all the time. You can't get dressed on your own. Your hair looks crazy and your armpits are dirty. You go to the doctor. You go to the doctor. They do an x-ray. They don't find anything because you don't find anything. It's not a bone issue. You get an MRI. You have a torn rotator cuff. Yeah, but most people over the age of 50 have a torn rotator cuff. It's probably not it. If it's the symptoms here, you might also have a torn rotator cuff. But a lot of times, a lot of people are asymptomatic when they have a torn rotator cuff. It doesn't mean it's the cause of this inflammatory process. And so, unfortunately, what happens is you end up in this cycle. You try PT. PT makes it worse, especially the type of PT that you'd be doing for a rotator cuff and not a frozen shoulder. And so, typically though, if I see somebody with all of these symptoms come into my office, oh yeah. So this, just to show you, this is the referral patterns. So this is where you'll feel pain if you have a rotator cuff tear. Isn't that funny that it's exactly the same? Huh, that's stupid. Yeah, I know. Yeah, it's exactly the same. And so, unfortunately, if someone has a rotator cuff tear, usually, so the most common ones, you're gonna feel pain on the side of your shoulder, right where you'll have the referral pain from a frozen shoulder. So, there are 3 phases of adhesive capsulitis. This looks like a lot, but I promise it's not. The first phase is the freezing, or sometimes you'll hear it called like the painful or acute phase. This is where you pretty much have like most of your range of motion, but it really hurts to like lift your arm up. It hurts at the end ranges of motion especially. You're starting to notice that your arm doesn't move as well as it once did, but you can still mostly do everything that you were doing before. A lot of times what you'll see, at least what I see, is I'll see people going like this to get things done. I'm like, okay. Unfortunately, that's a good compensation, but that too. But the biggest thing is people can't sleep. They're like, I haven't slept in 2 weeks. And I'm like, well, I bet you're feeling kind of bad. And they're like, yes. And so then, now, the problem with these phases, that's a huge range, 2 to 9 months. That's a huge range. And so, generally speaking, it takes, even if you were to do absolutely nothing for your frozen shoulder, it usually takes about 12 to 18 months to fully resolve, which is a really long time. The good news is it does get better. The bad news is we don't know how long each of these phases is going to take, but I have a trick. Please hold, it's the next slide. The frozen phase is when you start actually, your pain starts to get better. Like you're not having any pain at rest. Now the problem is you can't move your arm. Now the problem is you can go here, you can go here, you can't reach behind you, you have to buckle your bra in the front, you got to use your other hand to wipe. You literally can't go through a drive-through if it's your left hand. You cannot reach. That's one of the biggest complaints. ATM, forget it, you're going in. Again, 4 to 12 months, that's a really long time. And so the thawing phase, all of a sudden, it starts getting better. And you're like, that's weird. My shoulder has been hurting me for 9 months. Why is it all of a sudden starting to get better now? And then you start thinking about, what have I changed? What did I do differently? Nothing. You did nothing differently. It's the same. However, with the thawing phase, your motion is better, but your pain gets worse again. So now it feels like it did up here, but your motion's going in the opposite direction. So it's kind of happy, but it's also kind of sad at the same time. Now, the trick. Next one. Get a shot. So there is some research to show if you can get a corticosteroid injection, there's a little bit of debate over, like, do we get it in like right underneath our collarbone, or do we get it directly into our shoulder capsule? Most of the physicians that I've worked with prefer intra-articular, meaning it's put right into the shoulder joint. It's going right to the source. And so if you can get a corticosteroid injection, if someone recognizes it early and you can go and get this corticosteroid injection, what can happen is the process can stop. You can stop it in the freezing phase before it progresses to the frozen/thawing. research to show that like if you get an injection in the frozen phase, it can help with your pain if you're still having a lot of pain, but most people don't have a ton of pain in the frozen phase unless they're trying to like do something at their end range of motion. You don't typically have any pain at rest at that point, and so most people are like, I don't really need that. But if you're in the frozen phase, you are going through the rest of the process. You're not going to be able to reverse it. Unfortunately, it just is one of those things where that's just how the progression works. If you have or your physician recommends a manipulation under anesthesia, there is really no reason. The research does not support that at all. There is no difference between conservative care, meaning injection, physical therapy. There's no difference between that and manipulation under anesthesia, meaning, if you don't know what that means, it means you get put under, they move your arm as far as it can go and break apart the adhesions in your capsule. First of all, gross. Second of all, it doesn't help. I mean, people feel awful afterward. I've seen a few. It doesn't happen very often because it's not supported by the literature, but in a lot of really tough cases, what they'll do is they'll do a manipulation or anesthesia, and then you have to go to PT every day for 5 days in a row for like 2 weeks. They hate you. It really, especially if they're diabetic, it tightens up again because technically it's trauma. It's trauma to your shoulder. When things are put into trauma, they tighten up. So not only do you have a frozen shoulder, you also now have additional trauma. And so there are some studies showing PRP, which is the where they take your blood, they spin your blood around, and they stick it back into your shoulder joint. There are some studies that say that could help, but the studies are super, super small, and so I wouldn't personally recommend it to somebody yet unless they were desperate and unless they wanted to pay for it out of pocket, because most of the time it's not covered. Next. This is just showing the corticosteroid injections. If you can get a corticosteroid injection within about 2 months of all of these symptoms starting, you're going to be in real good shape. Again, it's not to say that your motion is going to be, you might still have to go to therapy to like get the motion that you lost back, but like your pain will be better, you'll be able to tolerate it better, and you don't have to go through the rest of the phases of the frozen shoulder. Okay, so frozen shoulder cheat sheet, because we just talked about a lot. So, are you a woman 40 to 60 or 70? Again, that you could be. I've seen a few women that are a little bit younger than 40, but most of the time, no. Most of the time, the women that I see with a frozen shoulder are in their 50s. 50s, like early 60s. Are you diabetic, or do you have a frozen, or do you have thyroid issues? Have you had a frozen shoulder before?
It happens multiple times?
It can. Well, you only have 2 arms, so it's twice.
Yeah. So it wouldn't happen to the same shoulder twice?
I won't say that.
Okay, so that.
I mean, it's unlikely. It's unlikely. But again, like there are some people, most of the time, what I'm telling you is 99% of the time this will resolve. You will have full motion at the end of the process, whether you got an injection and like stopped the process or whether you went through all the phases. You will typically be, like your shoulder will be normal at some point again in the future. But I can't say for sure that like it would never happen to the same shoulder twice. I don't know that answer. Yeah.
Did you say anything about, can men get this?
Yes, men can get this too. Yep. Men, a little bit less common. Typically the men that I've seen with this are diabetics, or they have a thyroid issue, or they have both. So that's typically where I will see a guy that's had this.
And it can actually happen even earlier than that, because I remember like when I started working out here, I was 30, I just turned 36, like 35, 36, and like within a year I was like telling Elle, like, I'm going through perimenopause. She was like, the hell you are, no you're not. I was, and I got this, and then I went to the doctor, they checked it all out, they were like, oh, you have a torn labrum, and I was like, I do? I was like, I didn't do anything, how the hell would I get a torn labrum? And then I was having like hot flashes like crazy, like from 37 to 30, so it happened really early for me.
And technically, it can't be a frozen shoulder if you're under 35.
So
like,
yeah, I
it
was like
can-
37,
It
yeah.
can happen like a little bit before 40. Most
Yeah.
of the time, no, but you're just special.
Yeah,
That's
we
right.
already know that.
So did the side of your shoulder start to hurt for no apparent reason? Are you having trouble sleeping? Is your shoulder waking you up at night? Can you lay on that side? Is it, does it hurt at rest? That's probably the biggest one right here, is like you did absolutely nothing. Your shoulder, like you all of a sudden can't use it and you're like, I didn't even do anything. What do you mean? And then, yeah, get an injection. Yeah, that's really
As
the
quickly
moral
as
of the
possible.
story, is like really the whole point of this was to help you recognize the start of this process so you can get in and advocate for yourself early. Because they're gonna wanna do an x-ray, they're gonna wanna do an MRI, and it doesn't matter if you have a rotator cuff tear or a torn labrum. Like, if you lift weights, you probably have that anyway. Sorry to burst your bubble. It doesn't necessarily mean that like that's what's causing the pain, and generally it's not. But yes.
So I'm a year and a half or 2.5 years past my frozen shoulder.
Congrats.
I don't remember how many years it's been, feels like forever, but I did get the injection immediately.
Good.
Because it was bad
Yeah.
immediately. But I still have a lot of shoulder pain, and so would you recommend continuing to get, I have it in both, but the frozen was definitely my left.
Yeah.
And then the right one just hurt, but not
Yeah.
horrifically, and I can,
Right.
do
So
things
so the right one probably isn't frozen shoulder.
but they really pretty much are like stabilized now in
Yeah.
in a more consistent level of pain.
Yeah.
But it also has to do, I think, with some of the exercises that I do with weights,
Sure.
you know, so I'm avoiding the ones that hurt,
Yeah.
don't do it.
And that probably, so you're probably past your frozen shoulder. Like this is probably.
It doesn't feel frozen, but I just still have shoulder pain.
Sure.
all the
And
time.
there's a lot of other reasons that
So do you recommend getting more shots?
No, I would recommend physical therapy.
I recommend physical therapy.
No, and honestly, corticosteroid shots are they're not very good for your tissues. And so
Yeah,
like you
I
really
don't
wanna
like
get
it.
one and then you wanna be done with it. Like it's probably more related to, you can still have a stiff shoulder and need some range of motion work even without being frozen. And so that's probably, so especially if you're going overhead or you're having most of your pain with overhead, like you probably still have some limitations, but it's unrelated to this.
Honestly, y'all, I recommend physical therapy for every human on the earth. I feel like if we had physical therapists for every person, life would be so much better, because they can fix a lot of stuff. And it is our daily habits that cause these little pains that we have. And they can spot what's going on and they can teach you how to fix it without having to have somebody cut on you or put drugs in your body, which is what we really want the majority of the time. Now, sometimes you do have to get surgery, sometimes you do have to take drugs, sometimes you have to do both, sometimes you have to take drugs while you're seeing Amanda. But ideally, we're gonna fix the root of the problem, where it's stemming from, which she can do a lot of that, which is why it's so amazing.
Question? I think.
Yeah.
Andrea?
Yeah, well, my question was similar to hers. Like,
Yes.
I'm pretty sure I've been suffering from this for several years. But, I went to the ER when it first happened. They said, oh, it's a torn rotator cuff. And I thought, oh, I don't wanna get surgery. So I
Sure.
just thought I would just keep on working out with it.
Yeah.
And so that's now at the point where like certain movements, I can hear it popping, like it's loud too.
Yeah.
And
And
so-
and then my hand falls asleep too, like at
Yeah.
night I can't sleep at all because it's just my hand.
That's
keeps
probably not a frozen shoulder.
falling. Oh, really? Okay.
No, that's probably, like, again, if it's popping, it's moving. So like,
Yeah.
it's probably more related to your stabilizers especially when you are lifting weights going up overhead. CrossFit does require a lot of weights up above your head, and a lot of people were never taught how to make that happen without
Engaging correctly.
Mhm. Yeah, thanks.
It's like the small women's group I've been doing with Elle
Yeah.
has helped a lot with my overhead.
Mhm.
And because we do a lot of small muscle tissue, so today when I was doing, you know, snatches, you know, it was a lot easier.
Yeah, absolutely.
Yeah.
And a lot of
course,
it,
working with me.
yeah, it takes a lot of work to be good at overhead. Okay, I think we're running out of time, so let's, two things. If you, go back. Oh, no.
We got it.
If you want this PowerPoint, you can scan this, just put in your name and email address and it will be sent to you. Also, anybody who is here today, if you're dealing with something or you want me to take a look at something, you can also scan this QR code. This is just a free chat about what potentially could be going on. And everyone, if you do sign up for an initial eval with Raise the Barbell, it will be 50% off today for just the people that are here. Not for everybody in the world, but okay. Nice to meet you. Thank you for everything.
Okay. We'll pass it around. Hey, I'm gonna try to get us moving a little faster. I know nobody knows it's been a whole day here. Okay, so next we've got my doctor, Heintges, and her nutritionist, Taylor Alef. So when it comes to nutrition, it is my least favorite subject because there's just so much out there. There is just so much stuff on TikTok. Y'all turn your TikTok off. It is bad for you. It is messing up your brain. So, and you are hearing all kinds of things that are good for you or bad for you, and just stop with it. Stop. All of it. Focus on eating like real food and don't eat too much. Like all of it. I have my favorite video I found yesterday, and it's this guy, these people in the 1950s, and they're making breakfast. This guy comes back from the past, from the future, and he goes, "Wait! Don't eat the eggs! They have cholesterol!" And they're like, "Oh, okay." And they start to get rid of the eggs, and he comes back and he goes, "Wait! New research. It's not the whole egg, it's just the yolk. Don't eat the yolk." Thank you. Comes back 5 seconds later, he's like, "Wait! I was wrong about the eggs. It's not the eggs! It's the bread! Don't eat the bread!" And he comes back like 6 more times, and he comes back and he goes, "We really don't know what we're talking about. Just ignore everything I said, eat your food." And that is like the essence of nutrition over the past 50 years, in my opinion. So I'm going to introduce Taylor and Dr. Heintges. I went to Dr. Heintges in November, and she was like, "Ellie, I'm starting my own practice." And I said, "Oh, you should come talk at my seminar." And she was like, "I would love to." So I'm so happy that she's here. She's absolutely wonderful. The thing that I love about this is she said, "I have spent so many years being an OBGYN, spending 8 minutes with my clients because the insurance only allows me to spend 8 minutes and then I have to go to the next person." So I got into medicine because I wanted to help people, and you cannot help people in 8 minutes. And it is frustrating me, and I want to be able to actually serve my clients. And I was like, you are the one that I want here talking to these women, because that is a real thing. So she is starting her own business, and it is a cash pay. It is expensive. However, I am just going to tell you, if you have a designer purse or designer shoes in your closet, I'd be willing to bet you've got more in your closet than you're going to spend on her, and that's not going to keep you alive longer and make you live a better lifestyle. It is super imperative to go to the doctor, get all of your tests done, get all of the pre-stuff done, know where you stand so that you can live your best life. Here's Dr. Michelle and David.
Hello. Fortunately, I don't need a microphone. Never have, never will. A little bit about myself before I get started, and thank you for introing how my goal is everybody to leave here today ready to go get on hormones if they weren't on hormones already. And so luckily, everybody's been talking about it. I have been in private practice. I'm an OB-GYN here. I'm originally from Oklahoma. I went to med school here at Southwestern. And I have been in private practice for about 24 years. And what I've seen, and we're going to talk about hormones, that's why, she was going to talk about hormones, and I was like, I can talk about that for 5 hours. But what I've seen, and you guys know this too, is that as time has gone by, people are not getting healthier. Patients are not getting healthier. They're spending so seeing patients come in to see me, young women, 38, 39 years old, overweight, high blood pressure, pre-diabetes, and they go to their internist and they get a blood pressure pill and tell them to come back in 3 months. And that was the visit. That was those 8 minutes that they got with their doctor. So that's kind of not why most of us went to med school. So a little bit about hormones in general and their history, because I love all the before this, because this is going to be so fun for me. When I first started in my residency, out of residency, I got really lucky. I joined a group of men and one woman. And the men that I joined were older men, senior partners. They were original to Medical City back in the day. And this becomes important because they were hormone people. They loved hormones. They gave women hormones from the minute I stepped into private practice, okay? So estrogen was really defined in the 1900s, was the first time they figured out the girl hormone, which is estrogen, okay? So time goes by, and it was in the 1940s that they came out with Premarin, which everybody's familiar with. They're like, oh my God, we got this horse urine, we're gonna make this estrogen, we're gonna help all these women that suffer X, Y, Z. So Premarin comes out, everybody gets on Premarin, that was really kind of the only choice that you had at the time. Well then, they realized, okay, just this estrogen this Premarin by itself, women are bleeding, women are having their uterus lining is getting thick, they're having cancer. So they recognized, okay, late 70s, early 80s, well, maybe we need to give them a little bit of progesterone too. And everyone's like, oh my God, that's so great, working great. So after all this, it really wasn't until the 80s till they decided, finally, we're gonna do a study for women. And that was the WHI that everybody hears about. We'll talk about that. And so the kicker with that is that it came out, its primary goal was to look at cardiovascular disease. That was it. It was for hormone therapy and cardiovascular disease. And so they specifically chose women for this study that were more at risk for getting cardiovascular disease. Women in their 60s, okay, that's not me yet, thank God. That's not a lot of people, premenopausal, postmenopausal, the definitions crack me up too, but regardless. Women in their 60s, and they were really just looking at the endpoint for cardiovascular disease, and the only medications that they used on these women were Premarin, which is conjugated estrogen, and a really bad progesterone that they figured out now that's not good. So they stopped this study. Oh my God, all these terrible things are happening to the women, primarily stroke. That's what made me stop it. In about 2002, I started in private practice in 2003. And so I got to see all these patients coming in, 79% decrease in hormone replacement therapy at that point when the study came out. 79%, that's a lot. Because everyone's worried and scared, so for sure the internists weren't doing it. And here go now, I'm in this practice, I'm with these men, and they've seen patients that they've taken care of for 35 and 40 years that are coming in because their internist is taking them off their hormones, and they are miserable. They're having urinary, they can't have sex, they have no libido, their vagina is painful, their vagina is dry, they can't sleep, they have anxiety, they have depression, da, da, da. I'm not even talking about heart disease, osteoporosis, we'll get to that in a minute. And so my senior partners are like, absolutely, we're giving these patients hormones, sure we're giving patients hormones. And meanwhile, while their internists are taking them off, so here we go. And that's when all this started, right? Well, of course, we know this just in our modern times. The bad news always gets all the attention, right? The bad news always is what everybody wants to hear about. The good news. So they completely, when they came out with this preliminary information on the study, they completely ignored all the good things that they had kind of sort of seen, even with this bad estrogen progesterone option, because we know now there are great options. And so everybody gets off their hormones. Well, what's interesting is that in some of the conversations that I've had with patients and some studies that we've looked at, so luckily for me, my mom's a nurse. She's 76. She's been on hormones ever since she had her hysterectomy. They are calling these women the women of the lost generation. This block of last 20 years of patients that have not been on hormone therapy. What have you seen? Well, miserable quality of life. The list is too long to mention. Increased number of women dying from cardiovascular disease. The #1 killer of women in the United States. more than all the other cancers combined. Cardiovascular disease, the huge amount of osteoporosis, osteoporotic fractures. I don't know if you guys, I looked up some fun numbers before this, but women over the age of 50 getting a hip fracture, your mortality rate in the first year is up to 30%.
Huge,
I mean,
huge.
that's insane.
And it happens from like falling off a curb.
Yeah, it's ridiculous. I had a patient that I saw a couple weeks ago, and I said, if you fall and break your hip, you're done. I mean, so when you're looking at women's health and being healthier, what Ellie was talking about, where let's preserve our health, let's preserve our longevity, let's reduce our risk of insulin resistance and diabetes, and what are things that kill women? Heart disease. Well, the new studies and the new information that has come out, it's not even so much new as it is them really delving into these studies that have been going on all this time and recognizing that there are different forms of estrogen, right? Everybody doesn't need this conjugated. When I say conjugated, it's basically bioidentical. I love that word. Patients ask me that all the time. It's a marketing term.
Yeah.
And what that means is, it's important, right? Because pretty much all estrogens now that women can be on are bioidentical. Because they're all synthesized from something. There's not like a farm where you dig enough estrogen and making a pill out of it. But they're all mostly, the healthier ones are synthesized most closely related to our, human estrogen, okay? Because we have receptors on our cells, and our estrogen is different than horse estrogen, and so what a conjugated is basically some synthetic rando shit mixed in with natural, right? Whereas now the bioidentical is just the natural, it doesn't have the fluff. So think about processed food versus whole foods. This was processed food, and this is whole food, right? And so we know that there are great estrogen options that are good for you. And then also too, that we know also that there are natural progesterones that are good for you. The killer of that study was the type of progesterone that they used specifically, which is a synthetic progesterone, right? And so knowing that there are so many good healthy options for you, and if you're looking at your health and how you're gonna stay healthy and maintain your health, I just wanna urge you to have an approach to your health that involves hormones. Because for women, reducing cognitive decline, dementia. Why do you think dementia's been going up through again, this lost generation we have here, looking at these numbers, heart disease, osteoporosis, osteopenia, and even if you have bone loss, osteopenia, we'll talk about that in a minute. Even if you have bone loss, while you have your estrogen around, your risk of a fracture is almost zero, okay? So if you go get your bone density done today, and you're 35 years old, and you have a little bit of bone loss, while your ovaries are still kicking and you have estrogen around, your risk of a fracture is pretty much zero. But if you are menopausal or postmenopausal and you have osteopenia, that risk goes up to about 38%. I mean, it's pretty crazy, right? And I'm not talking about osteoporosis. That's a whole nother level of bone loss. I'm talking about just a little bit of bone loss. Well, you don't have your estrogen around, and just a fracture risk goes up, okay? And so I just want to encourage you that if you are looking on working on your health, that you either pair with a gynecologist that is knowledgeable about this, because there's a big period of time in there where people didn't have training about it, they're not skilled about it because it was bad. So if you're seeing someone that's fresh out of their residency, they're not going to know a whole lot about it. They're not, because they weren't trained about it. Now if they're staying up and on it, they will be. But it's important for you to have someone that's pro-hormone, and testosterone comes into play. I have to talk about hormones forever. Pro-hormone, and then also recognizing that you having an internist or having a primary physician that recognizes that hormones are important in maintaining your health, prevention of these chronic diseases that a lot of people don't recognize. Because if you want to stay healthy, you want to be able to climb Machu Picchu, you want to be able to do all these things and reduce your risk of dying from heart disease, reduce your risk of having a fracture, osteoporosis. And actually some of the current literature supports that being on hormone replacement therapy has a decreased mortality risk for breast cancer of 50%. And
mom's part of that lost generation of women, and she comes with breast cancer in her history, and she refused not get on hormone replacement, and she went ahead and did it,
Exactly.
regardless of what the studies were saying back in that time.
And she probably doesn't have breast cancer.
God bless it, thank God she doesn't.
Knock on wood, exactly.
But part of the thing that I think, besides all those studies from back in the day that were giving mixed, you know, they weren't focusing on the good that was coming out of it and focusing on the bad, not knowing that, you know, at the time that they were getting the like fake non-Whole Foods brand.
Exactly.
Is also that it's always been said up until I would say probably the last 10 years, when you're talking about testosterone, when you're talking about progesterone, estrogen, you're talking about sex hormones. So women assess it with downstairs. And that generation of women was like, well, we're not having sex anymore,
Oh,
or we
well,
don't
absolutely.
care about, but there's so much more to that, like, cognition, the brain fog, the, like,
And
inflammation in your body.
joint pain, inflammation in your body.
Yeah.
You know, estrogen plays so many roles for us in terms of, you know, the sensitivity of our tissues, like she was talking about with reducing inflammation and having joint pain. That's important as well, to the cognitive decline aspect of
Yeah.
it. And then also, with the testosterone, you know, I have, so if let's say you come in to see me and your mother had breast cancer and you're not doing it, you're not, well, great, there's so many other things that you can do that can improve your menopause, improve your muscle mass, improve your bone density, etc. And so what I'm wanting to do in my new space is I'm really looking at, everyone's different, right? And what your goals are for your health. And then she was talking about the bone density. How can we, with your estrogen, you're going to be able to reduce your visceral fat, right? You're going to be able to improve with your testosterone supplementation and or your diet correctly. And everyone will be on GLP-1s now, and I'm not a negative GLP-1er at all, but I'm going to be a negative GLP-1er if you're losing your muscle mass at the same time. Okay? And so we're going to have the ability to, we're going to look at your muscle mass, and then we're going to work on XYZ, and then you're going to come back in 3 to 6 months, and great, you've lost 20 pounds. Well, let's look at your muscle mass. Like, okay, we need to work on this because it's important for muscle and strengthening in your bones and all these things. Anyway, I could talk about a lot of stuff. I mean, what else?
I had,
Yeah, ask me questions or not or whatever.
so let's talk about testosterone. Do women need it?
In my opinion, testosterone is the biggest game changer. Okay?
Amen.
I'll tell you, I have been, so when you look at all this information from the American College of Obstetrics and Gynecology, all these studies, even they recommend testosterone. Now, not for all the reasons why I think we can use it, but even they recognize, oh, testosterone has been recognized for improvement in low libido. Well, it does a lot more than that. And they also recognize that there aren't any prescription forms for testosterone for women. Okay, there are a bunch for men. So even they are supportive, which is crazy to consider the use of compounding testosterone for women. So that's pretty out there for the American College of Obstetrics and Gynecology.
I mean, we all have testosterone anyways, like,
It's
just as
produced
men
by our
have,
ovaries, right,
you know,
exactly.
So it's like,
Well, your ovaries make all your hormones, right? Not all your hormones, your adrenal glands also make them. So menopause truly is when your ovaries quit working. They're not making progesterone anymore, they're not making testosterone, they're not making estrogen. It's zero, none, zip. That's menopause, zero, okay? And so improvement in postmenopause for me, what's bothering, I'll tell patients, what's bothering you the most? Like, what are we working on here, right? And so testosterone is one of the biggest things that I've seen for patients, of course, libido, that's a big one, because estrogen's probably not gonna do a ton for you for libido. I mean, of course, if it doesn't kill you to have sex, your vagina feels great, that's gonna be way better, right? Because most people are like, I'm sorry, dude, that's gonna pass. But it's great for libido, okay, and also for muscle strength and muscle building and osteoporosis prevention, but it's been sleep. Sleep has been the biggest thing that I have seen patients improve with testosterone over and above anything else. And so, again, getting back to the pill throwing at people, oh, here, do you want some Ambien? No. That's not what we're doing here. Now, if you need Ambien, you need Ambien. Something happened, you're having something happening. But the goal is not for us to load up our medicine thing with all these, the goal for us is to be like, okay, here's your supplements I want you to take, and Taylor will talk a little bit more about that. There's different ways that women metabolize estrogen, and maybe we can help you metabolize your estrogen a little bit better or healthier for you, depending on how healthy your gut is. But testosterone for me has been the biggest game changer, and being strong and staying strong, recovery and exercise, right? You get off, you're gonna quit your CrossFit class because you gotta go pick up your kid, not because you can't do any more push-ups. That's the difference with testosterone.
So what is your approach in terms of, you've identified 3 different hormones, right? And so is it a combination, is it a ratio? How do you approach prescribing someone hormone replacement therapy? I've been talking to Elle about this a lot because I've been like, the cognitive part of it is unbearable.
Yes.
I've just always thought something else is going on. I never associated it with like a decline.
That is the
That was my biggest
problem
and
for everyone.
I just
Yeah.
I couldn't believe it. And I'm actually seeing my doctor this week. I'm excited about it. I keep calling her this past week, like, do you have cancellation?
Yeah, I was
Well,
gonna
let's
say, go
start
right
right
now.
now. And she had mentioned, she said that she started and she felt like she was back in her residency in terms of just being there, cognitively and not having that brain fog. And so, but what is that approach? Is there a combination? Is there?
Well, and so it's a good question. And so kind of like when we were talking earlier about pre-menopause and perimenopause, all those different, that is literally, you don't have any idea what's going on with that. Meaning, I have patients that have completely gone all the way over the bridge and they're 38 years old. I have patients that are 56 that are still having regular periods every month. Okay, so you very well could be experiencing symptoms and you think, well, no, to her point, oh, I'm too young for that. No, not necessarily. But the approach to hormone replacement therapy depends on the patient. Just as you're getting from point A to point B is different, what you're gonna need and require as a postmenopausal patient or even a perimenopausal patient is different. And it's all about symptoms and it's trial and error, right? And I say trial and error because you may be able to do, so first of all, I'm gonna choose a bioidentical hormone, right? I'm not gonna give you a synthetic hormone like a Premarin or a Duovi, or there's some other ones that are what they refer to as conjugated. So I'm gonna choose that. I'm gonna choose a natural micronized progesterone. And then we're gonna start. And then you're gonna come back, and again, this is another problem with the way that things are set up now with medicine. You're gonna start on this and we're gonna see how you're doing in a few weeks, right? And then, on this is how you may add a little this, add a little that, but every person is different. For me, I'm gonna start initially with a pretty solid, lengthy list of what are your symptoms. And then I'll look at those and be able to determine if you're not really having a whole lot of hot flashes and night sweats, I'm probably not gonna need to give you that much estrogen. That's probably gonna be a little bit on the lower side. But progesterone, if you're not sleeping great, we can do some progesterone, but it really is approached primarily to your symptoms. And so everybody is different. You're gonna be on a different formulation than I'm gonna be on, and then Ellie's gonna be on, and it's gonna be different.
Is there a point at a certain age that women should not take HRT?
In my opinion, no.
Because there has been that perception that at a certain age, 60-something, you should stop taking it. That's why I don't-
In my opinion, no. My mom is 76. She has been on oral, she had a hysterectomy, and she's in her mid-40s. They took her ovaries out at the same time, so that put her in menopause. Your ovaries not there, obviously they're not working. And she was a nurse, and she had taken care of some women that had ovarian cancer, which is the only reason why she had her ovaries taken out. Because right now, I wouldn't take out the ovaries, that's 41. And she's been on oral estrogen this whole time, and telling me the story of her walking down, she's a dog rescuer, walking down to the dog barn, and I fell 2 times. I'm like, she fell 2 times and got up and walking on down to the dog barn. So for me, my opinion, I plan on staying on my hormones. I plan on staying on my hormones the whole time. Yeah.
Okay, so part of, like, you go into menopause and your cholesterol goes through the roof. That too, in doing that first study, all about kind of heart disease risk, strokes, etc. So I did that. That went through the roof, and then like 5 years later, I find someone to put me on hormone replacement
right when it's happening, and that's what's going to keep your cholesterol at its best. Keep it from getting there.
I have a couple of questions. I'm going to address a couple of things before y'all ask questions, but I want to get a couple of things out there.
Okay, yeah.
So as women, our hormones are all constantly doing this: progesterone, estrogen, progesterone, estrogen. So is there a test that you can do to test if someone is in menopause or perimenopause?
Yes. Testing, hormone testing, there's been a lot of debate between salivary testing and blood serum testing. I don't think either one of them is necessarily superior. Salivary hormone testing tells you about right that very second. So if I have a patient that, let's say they're having migraines and we want to know if they're hormone related, maybe I would send her with a salivary kit. She's having her migraine trigger, check it. We can check and kind of see. But initially, the easiest thing to do with it is going to be blood testing. I'm more comfortable with serum testing because I have more experience with that. But let's say you come in to see me and I do your blood test. This is a funny fact. You guys will like this. 70% of patients that go in with complaints to the gynecologist or the physician, their blood work is normal. I was just looking at mine.
Mine is all normal.
Yeah, right. Like that. 70%, right?
She was like, no, it's not.
Well, yeah. I mean, honestly, you're not ovulating regularly. I mean, there's a reason why you don't necessarily get pregnant when you're 45 years old. Hello. So your ovaries aren't working the same way. Your progesterone's not the same. And so, yes, serum testing, but serum testing in combination with the patient. Like, you just have to have time to talk to your patient about what's going on. And serum testing can be good to use for monitoring patients' response to different therapies, like how well they're absorbing. Are they absorbing their estrogen? Maybe I would give you. I'm more of a transdermal fan myself, more so than a pill because it bypasses the liver. But if, let's say you can't do that, it doesn't work great. But I've had patients come in to see me on oral therapy, just having terrible symptoms, and then we'll check their labs, and it's like they're not even on anything. It's like they're not even. She was like, "Well, how could this be?" I'm like, "You're not absorbing very well." And Taylor will get to that a little bit as well too. And so, looking at how well you're absorbing, how your body processes these different estrogens, different for everyone. Making sure your gut is healthy so that you can absorb things the correct way. I'm sorry.
Do you do the Dutch testing at your practice?
Pardon me?
Do you do the Dutch testing at your practice?
No. No.
Another question. If you have had cancer or are at high risk for cancer, can you be on HRT?
Yes. So, let's say you've had a breast cancer and it is positive for estrogen progesterone receptors. You guys know what I'm talking about when I say that? Some of the new data that's coming out right now is supporting people being on systemic hormones after 5 years, which is crazy, right? But let's say that those patients, they had an estrogen or progesterone receptor positive breast cancer, and they're worried to get back on it. Fair and safe. Testosterone therapy is not contraindicated at all, and it can alleviate all of your symptoms: hot flashes, night sweats. And then there's no debate about the use for a topical, as she was mentioning previously, the physical therapist from Genesis, a topical vaginal estrogen to improve urgency, frequency, dryness with intercourse, those types of things. But there's always going to be something that you can do to improve your menopause and postmenopausal symptoms, improve your health, if you don't want to be on just strictly estrogen.
Go ahead, Sean.
Yeah.
So do you have a preference or recommendation over what I call pharmaceutical hormones versus a compound?
No, not really. The typical estradiol patch, that's a bioidentical hormone. Estradiol oral, that's a bioidentical hormone. Estrase, most of the newer ones are just the same that you would get at a compounding pharmacy. Now, you can't get testosterone pharmaceutically. And then prescription, they have a prescription micronized progesterone. That's a natural progesterone. I wouldn't give you a prescription Provera. That's like not a good progesterone. But I also like compounding pharmacies. I work with compounding pharmacies because patients, for me, it's about how are you going to do what you're supposed to do.
Yeah.
So some patients prefer a cream, or they want to do this, or they want to do that. I particularly, and they're positive, I particularly like pellet therapy. I'm a terrible patient. I don't wash my face before I go to bed, like do all these things. And so the pelvic therapy is good for me because I go every 3 to 4 months. My compliance is spot on.
Like, the gynecologist, he would only prescribe what he wanted to.
Well, that's what, yeah, there's so many choices.
So one of the things we said right off the bat is when you say he.
Yeah, and if honestly, like if you are going to a gynecologist that doesn't want to prescribe you hormone therapy, I'm telling you, you have got to get a new gynecologist. Like that is insane.
Well, he was willing to do that, but it had to be only how his way.
Yeah,
Not
there's
versus
so
the
many. That's when she was like talking about
As
hormones. I'm like,
many
girl, there's
women
like
as there
bajillions of things. And the other thing about it is every postmenopausal, perimenopausal symptoms, whatever word you guys definition you want to use, whatever, it's 100% fixable. I've had people come into my office, they have not had sex in 5 years. Because their vagina, I'm like, why are you doing this? Like, what are you doing? I mean, we're supposed to be tearing it up now, right? We have our kids over the house. I'm serious. Like, I can fill my car with gas. I'm not worried about like $7 at the pump. Like, and so, but if you don't, it's true. But my point is, it's all fixable problem. And whatever it is, maybe you, and all these add up together to get to, you're not sleeping at night, okay? So now your cortisol is up. And so now you're getting fatter on your stomach. Well, you don't have any estrogen. So now, instead of having sub-Q fat, now you get more visceral fat. Now you get, it all goes together with a bow on top. But it's totally fixable.
It's never too late?
Never.
Too late. Even if you're in your 70s?
Never.
Never. Never.
Yeah.
So, like you say, there's a vast amount of information out there. Facebook is always one of mine.
Yeah.
I can't stop listening to it, even though I'm not going to click on it, even though I did sometimes. But it all boils down to me, to a great extent for so many people, is finances. Because everyone's going concierge doctor now. Everything's going physical therapy out of pocket now.
Yeah.
I did this $300 a visit physical therapy, for a good while until I thought, okay, that's enough money on that. And you just start putting money in all these different sources, and for many people, there's a limit on this investment. Okay, you can talk about how important it is and all that, and how you'd spend more money on whatever, but it's almost like the principle of the thing. I'm on Medicare.
Sure.
And I'm paying some serious premiums here, something ought to be covered.
Yeah.
And
so there are prescription hormone therapies that are covered by your insurance, that are natural hormones that are perfectly safe for you to take, that you can see your gynecologist and get. But I encourage you, if you're to do it.
And it's harder when you're in your 70s because insurance is less likely to cover in your 70s.
But you can have osteopenia.
I have everything.
But
I have every
I'm saying-
single thing.
No,
There's not one single thing you have.
But what I'm saying is, that's an
I have
indication.
all of it.
That's an indication for your insurance
And I'm on
to
hormones.
pay for your hormones. You know what I mean? Like,
Let's
then
talk
are they
about
going to
it.
pay for your hormones in your 70s because you're saying you're having hot flashes? Probably not. But if
Oh,
you have
yeah.
bone loss,
Oh, I have them like crazy.
they'll pay for that then.
For
Or
25
make up
years.
something.
Yeah.
Hell yeah. Make up something. Like, what do I need to write on here to get this approved?
It's all about coding.
So my doctor
Code
just
so bad.
put me on cholesterol medication, which I don't want to be on, but
Yeah.
she insisted.
Marianne.
So anyway, it's fun. I guess it's just finding the right source to figure out how to find the right things,
Yeah.
and that's
So
a whole
that's
lot of
why
research.
I wanted to have this today, because I have clients that come to me all the time and they're like, I went to my osteo doctor for my shoulder and I have a tear, and then I went and saw my gynecologist because my shoulder hurt, and I went and I'm like, your gynecologist is probably not gonna help your shoulder.
And could your gynecologist, do they have the ability to do that? Sure, but they don't have time, right? They gotta stay in their lane because they gotta pay their bills, sadly. And like I tell people, that's why you can't call and talk to a patient on the phone. Like, most of the things hey, can I just talk to the doctor? No, unfortunately you can't, because that'll take 30 minutes and they have to be grinding in here so they can pay their overhead. It's terrible. and it didn't used to be this way.
Yeah.
And what I've seen is my patients, that people aren't getting healthier, it's not working, I don't know, I don't see it getting fixed in my lifetime.
Well, we are seeing it getting fixed when you guys come work out and get your diet together and we have these conversations.
Improve your muscle mass,
The
reducing your
conversations also are hugely important, and girls supporting other girls through this time and having those conversations is vital. It really is. That's what's gonna get us to the next phase.
True. Hi, Stephanie is my little patient. I didn't even know she was going to be in here. I hope you don't care if I told people this. Hippa, hippa, hippa. I was like, oh.
If you're looking for an amazing
Oh, you're so nice. Thank you.
doctor and you can take the
You're so nice. I'm right next to the Carroll Clinic. In the Pyramids building, right by my car.
Well, she knew Julie Beekler in college.
Oh, she was my cousin's sorority.
Oh, okay.
So y'all, they had met in college.
Oh, okay, maybe that's
Yeah,
why.
yeah,
Okay,
yeah.
that's fine.
That's how I found her, was through Julie Beekler.
Okay.
Yeah.
I do have one quick question. My mother's 89, she's in great shape.
Good.
The problem she had occasionally is at her age, PTI.
Oh, okay.
So, and she had breast cancer at 82. Not a big deal.
If we all live that long, we're probably gonna have some kind of cancer, yeah,
Right,
exactly.
right. So I told her perhaps an estrogen gel.
Vaginal,
That's
local.
what I mean, a vaginal estrogen, so that's fine, right?
100 million %.
A lot, okay.
Is that over the counter?
No.
That can take you down when you're 89.
A UTI, absolutely. And it just be a topical estrogen, and even if a urologist will probably prescribe that. She's just seen a urologist, yes.
Okay.
Absolutely, she should do that. Love you, Dr. Stephanie, love you, good to see you.
My doctor never says they love it.
April, what's that?
I said, my doctor never says they love
I didn't even know she was coming. She goes, I saw you in the advertisement or something. It was so cute.
Everything I want to hear.
She's so nice.
Right.
Yeah.
So this kind of goes along with all of what she said as well, because I'm kind of in the same situation after, threatening my gynecologist with my internet hormone lab stuff. He said, I'm gonna buy it on the internet, we just prescribe it. Kind of have all these things, but she has like a 3-4 month wait list. And so my question is, I have the prescriptions for these things and I'm also terrible
Yeah, I'm not so good
conformer.
myself.
But my question is, do your hormones continue to fluctuate? Because I would love to be
No.
able to have a doctor like you that I can go to and say, where's the sweet spot?
Yeah,
Like,
do they continue to fluctuate? No.
Conservatively, they're.
Yeah, once your ovaries kibosh it,
Uh-huh.
you're typically in a pretty good spot unless you have some significant changes otherwise, like you more stress and your cortisol's going up, you lose a bunch of weight, gain weight, that kind of thing. Typically the hormones are metabolized by your cardiac output, so if you're training for a marathon, or you're coming in here with Ellie, like maybe we're gonna need, that would maybe have you kind of run through a little bit faster. But everything else being the same, you should stay pretty steady on your dose unless
Just
you
kind of
have,
based on how.
unless you have absorption
how you feel.
issues. Yeah, unless you're not absorbing, all of a sudden you're taking an oral estrogen and you're coming in bad, we would wanna check and see, or you have something going on with your gut. Is that why, your gut's not healthy, why you're not absorbing your hormones?
Okay, I wanna bring Taylor
Okay,
before we
Taylor's
run out of
gonna
time.
knock it out here, and Taylor
I know
is
everybody
also
has
one of
so
my
many
patients.
questions.
And she's just finished her functional and integrative nutritionist, and she's gonna be working with me in my new space.
Oh, nice.
Yeah, awesome.
And welcome to conversation. There's so much of what's already been talked about that overlaps with what I talk about, and so it's just great to hear it. And being in the functional medicine space, root cause, I think I heard that term 3 or 4 times already, and it's just really figuring out what is the root cause of what you have going on. Are you trying to optimize your health, or do you have symptoms and you're wondering, okay, what the heck is going on and if something's up? Well, figure out your why. Why do you have this? Don't just put a Band-Aid on it, take a prescription, figure out what's causing it, and that will make you much better off in the long run. So obviously our nutrition needs to change as our hormones change, as our bodies change throughout our lifetime. Your hormonal shifts are gonna do some crazy things. Not all of them you're going to love, as we've talked about. It affects your metabolism, it's gonna affect your body composition. We've already talked about how as you age and your metabolism changes, your fat mass will go up, and like that, your muscle, will also decrease. So there's gonna be a lot of themes and threads that you see throughout this presentation that are very similar. The insulin resistance can also become very common with women as we're going through menopause. And then sleep and stress. When we were younger, we could abuse our bodies and it didn't really affect us like it affects us now. But as we age, lack of sleep, high amounts of stress really can create major issues with our hormones and with a ton of other things that we have going on in our bodies. The next one. And it's not always willpower. Sometimes it really is physiology. So we beat ourselves up saying, well, if I didn't eat that, or if I had gone to the gym a few more times, that's not always the reason as to why our bodies are changing and we see differences in our abdominal fat and other things like that. So there is a lot of willpower and dedication and discipline associated with it, but that is not the whole case, and do not beat yourself up over something like that. Again, go back. Oh. I don't know how to go back. And then sometimes we also think like eating less is better, less calories. Not always the case, especially as we're aging. I don't want everyone to think restriction. Think, what can I add back into my life? What can I add to make it better? Don't always think, what can I take out? So it's a very big difference between the two of those things.
I would say use the word nourish.
Nourish,
How do I
yep.
nourish my body, my
Yep.
soul, my brain, all of it? Put things
Yep.
in your body that nourish you.
Because if you're not nourishing, then what happens? You feel like crap, you're fatigued, so then you don't want to go work out, you don't want to meal prep and make healthy things for yourself. So it's just a ripple effect of all the things that it affects throughout your life. And then chronic dieting also throughout your life can create really crazy hormone imbalances, and obviously there's been a lot of hormone talk. So just making it well balanced, eating steady meals is the way to go. Protein. If you heard how many times a day I say protein, it really is that important, and it's important when we are young, but it's really important as we age. It's really important when you go through menopause. It is such a priority in your life, and it's a non-negotiable. Like it's a must-do for everybody in this room. You have to do it to preserve your muscle mass, your metabolic health. It helps with your blood sugar, stabilize. It keeps you full, so you don't feel like you always have to keep eating. It'll just keep you satiated way longer than other items will. I aim for protein at every meal. I put 30 grams with a question mark because there is not a magic number. I cannot give you a magic number. But for some people, 30 might be no big deal, and that's not enough for them. And for some people, you might think, oh my gosh, 30 grams at every meal is a lot of protein. So it just depends on you and what your body needs. But you have to look at what kind of, what your current weight is. You have to look at what kind of endurance training you're doing or resistance training. There's so many factors that play a key role in that. But think 30 grams at every meal gets you eating 3 meals a day, 90 grams plus snacks, protein shake, whatever, gets you over 100 grams a day. I think it's at least a good place to start. But there's a lot of, that could be not enough for some. And then protein for GLP-1 users. There is a lot of talk with GLP-1 medications. I'm like, you're over protein.
I know.
It's one of those things where I know people have talked about it already. I think Dr. Heintges mentioned it. If you're on a GLP-1 medication, your hope is, well, diabetes for the first use, but then also for a weight loss medication. You're hoping to drop weight fast. With fast weight loss comes fat mass loss, but also muscle mass, and it can be very significant. That graph up here, I don't really want you to read anything, I just want you to see, so 12.7 and the 22.4, that 12.7 is how many people have a nutrition deficiency within the first 6 months of using a GLP medication. The 22.4 is after 12 months. So it's not to scare anybody, it's just to be very aware that you have to make sure that you're eating. And when you are eating, you have less of an appetite typically on those medications. When you are eating, make sure you're prioritizing the protein and all the other things that come along with it that are healthy.
And I actually was reading something recently that was talking about the new, the first one came out, which was the Ozempic, and then the new ones that are out, the tirzepatide, works a little bit differently than the first GLP ones, and they actually selectively use amino acids for your fuel. They selectively burn amino acids, which are the building blocks for protein. So it's like double trouble for protein.
Yeah. Yes. And if you do not eat protein, your body will eat your muscle. That's basically.
Well, that's exactly.
It's sarcopenia. That's literally why you see little old ladies who are teeny tiny and walk with a cane because they don't have the muscle mass to hold up their body. That's why trying to fight the loss of muscle.
Does it matter what kind of protein? Whey.
You really want to get a complete protein of some sort, which is typically going to come from a lot of animal products. You can get complete proteins through other ways too, but no, I mean, like animal, plant, anything that you can get, really beans, lentils, things. Yeah. You know the next one. I'll start talking about protein for now.
I say I agree. I'm not a medical professional, so my opinion really doesn't matter. But I agree with protein, and my doctor has cautioned me on the like. I feel like our society in America has become like pendulum swung on only caring about protein at the detriment of fiber very specifically.
Yeah.
I don't know if my question is in there other than like.
No, I don't disagree. I think that we get on these like hot topics and sort of this buzzword, and like even Starbucks has protein drinks now. I mean, protein is literally everywhere you turn, and it's a hot buzzword. But fiber, extremely important. I even have it for too much. As you age, your motility in your gut slows down too. I mean, you need fiber for that reason. Water, hydration, exercise, all those things play a part in like getting your gut moving. Fiber is also, Americans are not great at getting a lot of fiber. Where are you getting fiber? Fruits, vegetables, nuts, seeds, like all the things that our doctors or dietitians always say, you gotta eat more of your vegetables. No, it really is true. We do not get enough of it, and they just our gut is kind of stagnant.
So I feel like it goes back to the whole
Yeah. Oh, I'm talking fiber.
Fiber.
Yeah,
That's what I meant by that.
Yeah.
You have to eat a lot of vegetables, because I'm big on the fiber kick lately. It's
Yeah.
like,
Yeah.
yeah. Hard to work to get that too.
Yep. Yep. Yeah.
I love it.
And if you think about how much you actually have to put in your body, fruits and vegetables to get the amount of fiber, it's a lot. Yeah, it's a lot.
Yeah, it is.
And that goes back to nourishing, right? Yeah. One of the things I tell people is don't put things in your body that melt in your mouth.
Yeah.
Because carrots, broccoli, all of those things, you have to chew them to break them down, and they have fiber in them. Meat, all of that kind of stuff, you have to chew them. They break down, go through your body. Bread, you can let it sit in your mouth, it will dissolve, and you can just, it goes away. You don't have to chew it if you don't want to. And it's just food that you have to chew.
And then with muscle health, there's also bone, which has also been talked about. You're going to see two themes repeated in this slide too. It's going to be proteins on there and strength training. The two biggest things I really can say, like take away from here that you need to do to make sure you're doing every single day. There's also the micronutrient aspect of it too. You want to look at getting calcium and D and K2 and magnesium. So there are a lot of the micronutrients besides just protein that will help with all your muscle and bones as well. Sugar and belly fat, talked about the insulin resistance. Your blood sugar can get kind of crazy as you're later on in life. It can drive your cravings, and it can do a lot of dips in how you feel. Make sure balanced meals is going to be the biggest piece of this, and just making sure that you're getting balanced meals throughout the day to help with the cravings and to also help just with your metabolism and helping reduce the abdominal fat that we always talk about or concerned about. And then gut health, I already touched on this too, like the fiber part of it, fiber, hydration, and your exercise. A lot of people will take a walk after they eat because it's just to keep your gut moving, it's the motility moving as we age as well. And then sleep and stress, always a fun topic because these are very hard to control sometimes. We know that with hormones, and those are fluctuating, lack of sleep can be a big problem. Stress, as we age, there's different life events that happen that stress really can increase. It does disrupt your hormones, it disrupts even like how you feel as far as like hunger. You just want to make sure if there's everything you can do in life just to help with those two things, because like alcohol, I know y'all with it, like as you age, alcohol hits different. It really does. It's not like when we could abuse our bodies when we're in our 20s and 30s and think we're going to pop out of bed the next day. You really do. It does disrupt everything you have going. And then last but not least, this is just like my soapbox things that I like to talk about, but I could talk about all day, but just some healthy reminders. The first one that we've already talked about is look at all aspects of your health. Nutrition alone isn't going to fix it. Exercise alone, you really do need to look at all aspects of your life. Stress, hormones, sleep, social connections. I mean, there's so many parts of health, and there's so many different pillars of health that we really do need to focus on besides just nutrition or exercise. I loved that you said TikTok earlier because there's much misinformation out there, especially when it comes to nutrition. So it's why I have a job, honestly, because there are so many people that say, I saw this on TikTok, and I'm like, you lost me on TikTok. I can't, you know, and I worry that it's doing more harm than good. But if you think about health, think about the basics. Let's simplify everything that we hear and we learn, and I think we get very confused, and sometimes, you know, I just think we just get a little like anxious about it. You're like, well, so-and-so told me I have to do this, and so-and-so said I have to do this. Well, go back to the basics. Are you getting 7 to 8 hours of sleep? What are you eating throughout the day? You know, just think about what you do on a daily basis and go from that. Do that first, and then worry about all the other stuff later. The detoxes and the 10-day cleanses and the magic pills, it's really not working. You may see some results with some, I don't know, but for the majority of them, I would stay away from all of the fats.
And on that note, I'm gonna go through a list and let her just rate them real quick at the end of this. So you don't have to ask questions.
And then remember, it is a marathon, it is not a race. Do not expect to do these changes overnight. There are some people that can, like my husband, and it's really annoying. He could just like stop something like that day and he's fine. He could just like get rid of coffee or just like stop eating sugar, and I'm like, like I have to like, it's a slow roll for me. I have to like slowly work my way into that stuff. Do not think that you're going to be perfect the next day, and it's just going to be, it could be, you know, take you a long time to achieve something.
And there is no destination.
No.
There is no destination. It's not like you're gonna Sunday hit this point where you have abs and like your life is better, and then that's the end, because it doesn't happen like that. This is a long journey if we do it right. The goal is to enjoy the journey, not try to find a destination. There is no destination, okay? That's a really hard thing to learn. That you're nourishing for this moment in time and trying to just have a great life and a great moment. Not because next week I'm going to the Caribbean and I want to wear a bikini. That doesn't exist.
1 week.
I know. I can't imagine how many times people come in here and they're like, I need to lose 27 pounds within 3 weeks. And I'm like, good luck.
Yeah.
Good luck with that.
And we already touched on this. Restriction is out, nourishment is in. I mean, that is really a huge thing to keep in mind as you're going through your journey throughout life. Don't ever compare yourself to others, because there could be somebody the same age at the gym with you 5 days a week, but your genetics, your biology, what they do at home, there's so many different factors that go into it. Stay in your lane, focus on what you know about yourself and your body, and just try to be the best version of yourself, because there's so much comparison along with social media and all the other things that you see, that you really just do have to stick with what you know, and you know your body best. Put the scale away. I think a scale is one of the most hate box. It's just
It's the hate box.
It is. It's the most. It's just very depressing, and it can be very
I think
discouraging.
you just have to realize like it ebbs and flows, and
Absolutely.
then I think women of the older generation thought less is better, and then the newer generation you realize like it's body comp.
Right.
If you're more muscular, you're gonna weigh more weight.
Sometimes I get excited when clients
Yeah.
go up in weight. I'm like, sweet, because you know, you can see when we use an in-body analyzer at Elle, it shows you, what fat you're losing and what muscle you're gaining. I might want to see.
I've weighed every
You never
single
know.
day for the last 20 years. As soon as I put it away, which I did recently, I gain weight. I gain a lot.
It happens. It happens.
If I weigh every day, then I know where I am based on what I ate yesterday for the most part.
Yeah.
And
It
I can
does
keep it.
fluctuate so much, like a woman's cycle or what you eat or drink. I mean, it does fluctuate throughout the month, regardless of what, that'll always change. But I think sometimes some of what we do can be so mentally exhausting and so mentally unfit that's my reason for wanting people to put the scales away, of just saying, hey, okay, like, let's not worry about that. Let's look at how do we feel. Before you look at a number, how does your body feel? Do you feel better? If you feel better, then that's the goal.
I raised muscular kids, and one of them was a girl, and I had a great doctor one time that said, put on tight clothes and just put them in the top of your closet, and that's how you should measure. How you, because your muscle, you stay muscular.
And then last but not least, if something feels off, it probably is. If there's something that you've been dealing with for like the worst fatigue ever for 2 years, and you feel like you take a nap after you eat, or like just some really crazy things where you're like, something just doesn't seem right, do something about it. Get it checked. There could be more that's going on, and again, get to the root cause of it. Find out what the why is. That's the biggest takeaway.
Hormones.
Yeah, it could be
No
hormones.
doctor
Yeah.
will agree with
Okay,
that.
so I'm gonna give her a couple of things to answer on collagen, yay or nay?
Yay.
Simple.
Yay, collagen? Any questions on collagen? Does it help your muscles?
Testosterone improves your collagen.
And there's
Oh,
different
I
kinds.
didn't know that.
Just
There
saying.
you go.
Okay.
And not all collagens are created equal.
Yes, there you go.
That's a very big.
Okay, what do we look for in collagen?
Oh gosh, just with any sort of supplement or anything you're taking, just a very reputable company that makes it. You do need to look at the ingredients.
We
the
do sell
fillers,
Thorn, we sell that
Thorn is
here,
great.
if anybody wants
Thorn
Thorn.
is a
And I think
great
you guys sell
company.
Thorn, yeah.
Yep.
Creatine,
Great.
great.
Yep.
Would you say creatine?
Creatine, yep, and better for some than others. If you are high endurance, vegans and vegetarians, or it's great for, because you can't get creatine from animal products. So there's different people that it's actually better for than others too.
Okay, it also helps brain fog.
Yes.
Okay, multivitamins.
Yeah, yay.
Okay,
A good one.
evening primrose oil.
There's a lot of research on this actually with menopausal women, and I would say yay for that.
Okay, milk thistle.
Yeah, I've heard some good.
Calcium,
Yeah, great. From food. I think
From
always
food.
prioritize from food first, please.
Nutrafol hair.
I haven't personally used it, but I've had husband, mother-in-law, I've had so many people using it, and I don't think they see much of a difference with it, so.
Just high vitamin.
Yeah.
Is there anything that's good for brain health?
Oh gosh, everything?
Like supplements.
Supplements? Oh gosh,
Provision.
there's so many. I mean, there's so many, so hard to even say.
Okay.
Obviously, hormones.
These are my questions that I've been given. Does sugar cause cancer?
It creates an environment in your body, I think, which it can definitely thrive on. And it definitely is a high risk factor. So for instance, if you do or do not know, but it increases breast cancer significantly, esophagus, mouth,
Inflammation.
colorectal, huge inflammation. It's damaging your DNA. A lot of problems with it that's creating a really great environment to get cancer. If it's excessive.
Does sugar cause Alzheimer's?
Yes, I would never say it causes Alzheimer's now.
Did you say
sugar cause
Alzheimer's?
Again, I think a lot of these like refined foods or sugar can create environments in which your cells don't reproduce in the correct manner, and so that in turn can create disease and all those things. But I wouldn't say it directly causes. You can't directly cause.
Seed oil versus saturated fat.
Seed oil, there's so much talk about seed oil and inflammatory factors. I don't know if I agree with how much excitement there is over the seed oil thing. I think it's the amount of seed oils that are in all the foods. Anytime you look at a processed or ultra-processed food, seed oils are always going to be top of the list. So I think it's just the amount that we're eating, which is in turn causing a ton of inflammation in our body. And we also look at something that's like an omega-6 to omega-3 ratio. Some of the oils are higher in omega-3s, omega-6, but it's just, and omega-3 is known to be more anti-inflammatory. So it's getting that ratio balanced where our omega-6 are like off the charts and the omega-3s are down here. So it's more just like a balance of what types of fats and omega-3 health we're getting.
What I see with people is just too much fat. I mean, if you're frying your food, there's a problem.
Yeah.
You can use a little bit of oil to keep it from sticking to the pan, but you don't need a cup of oil with your food. You just don't. That's the problem, is you just get too much fat, period. It doesn't matter if it's saturated or seed oil. Okay. Most of the time you find seed oils, it's gonna be in highly processed foods. That's another problem. So try to stay away from the highly processed foods. Yeah, you're safe. Parasites.
Anything specifically about
Yes.
parasites?
This is a TikTok thing that we all have parasites and we need to do a parasite cleanse.
What? We do not all need to do a parasite cleanse. I am not an expert on parasite cleanses, and I will say that first and foremost. I do think there have been some very little tiny bits of studies done that maybe there are some that help. I don't think there's honestly enough evidence for me to really talk in depth about it. I'd say more like
This is a question.
Yeah.
And what does an appointment look like with you?
So I usually do a lengthy initial appointment because I literally get to know you more than you ever wanted me to know you, just with talking about all the things you eat in your sleep and your social life and your, we just talk about everything. I wanna know all about you and your health and your lifestyle. I usually take like a 90-minute initial consult, is what I call it, with patients. And then from there, I typically do an hour, or if somebody wants 45 minutes or a half hour, and we do a lot of follow-ups to just kind of see progress and see where we need to change, the things that we talked about and what we're gonna do moving forward. It's a constant changing, ever-evolving thing that we do, and so it's really up to the clients on what they want. But I really do get to a deep dive in the beginning, and then we kind of go as we see fit.
Do you do performance nutrition?
No, I mean, they're very little of it. There's some people that really like that is their specialty and their niche, not mine. I'm definitely the integrative and functional space, but there's other things that I do, but there are others that just specialize in only that. Yeah.
What about the functional mushrooms that you're hearing about so much?
Yeah, I mean, there's so many beneficial things with mushrooms. I like talking about brain health. That's one that comes up a lot now. They have coffees, all these things. I do think there are a lot of benefits to mushrooms. There's a lot of functional properties to a lot of the foods that we eat, and that one's definitely been a hot one as of late. But I do think there is beneficial properties of that.
How do you feel about nicotine?
Nicotine?
Not cigarettes.
Yeah.
But nicotine. Pure nicotine.
I don't know about that one. I don't know if you have a good answer on that. Is it for energy reasons? Is that why you're saying it goes to cognitive? No, I honestly.
Yeah, there's been a lot of.
I don't feel like there's enough research on it.
Yeah, there's been a lot of talk about nicotine recently, and I think I'm of the opinion that when something becomes popular, you wait 2-3 years and see how many die or freak out, and then if it looks good, then you can take it.
Yeah, I'm with you on that.
How do you feel about intermittent water fasting?
It depends on who it is, because with people's blood sugars and different medical conditions and medications around, you have to be careful with intermittent fasting. I do like intermittent fasting in a way that if you stop eating dinner at a certain time and you don't eat until, you give yourself a good 12 hours of no eating, I think it's a great rest for your body and your gut and a lot of other things going on. The water fasting, it's okay. I mean, I wouldn't probably recommend it, but I do think certain types of fasting are good. Just different lengths of time to not be eating and consuming.
Any other questions right off the bat? I have one more. Go ahead.
Are there any natural foods that boost your natural estrogen, testosterone,
Oh gosh, there's tons. Yeah, there are so many. I would Google that or whatever. They'll give you a whole host of different things that.
Like soy is the most common one mentioned, but there are more than that.
Yep. But there's so many that can really help boost that. So as we age, it's cruciferous vegetables. There's a whole bunch that you could go through and see.
I always think of yams from Sex and the City.
It's true, yams and soy, that's what they get
where
it's from.
Sam was bathing in yams.
Yeah.
So I do have one more person that I want to talk to you guys really fast. I was at a party over Christmas, and I was talking about this seminar, and she said, "Oh, you should have me come talk. I'm a dentist, and I can talk about what happens to your mouth in menopause." And my response was, "Shut the fuck up." I was like, do not tell me that there's more shit that I need to worry about in menopause. I am not prepared for this mentally or emotionally. So, real fast, I'm gonna let Brenda come talk to you guys about your teeth in menopause. Thank you, Taylor. Thank you, Michelle. I was laughing so hard because I was like, I'm not ready for this.
I'm actually a little obsessed with dental health and dementia and all that those
It's
stuff.
all new.
Yeah.
It's
So,
a thing.
I won't take very long of your time because I know we're way over. But you were talking and I was like, they're all linked, and I'm so glad I actually went out to a nutritionist because that makes perfect sense. With your teeth and with menopause, a lot of things people don't realize is that your teeth link to your body. You don't know where we separated them a while back, but they are connected. So I'm Brenda Pia. I'm a practicing dentist in Plano, Texas. I've been practicing for over 10 years there. I'm actually working on opening up my own concierge dental practice in Dallas soon, so you guys will see me there. But I really just wanted to take this moment just to help you guys connect the dots. When you lose estrogen in your body, that actually affects your gut health. and your gum health and inflammation, it's all boiling down to inflammation. So when we have those hormonal changes, we'll see like that you'll start to notice your gums starting to bleed more, that there's puffiness that's happening, and especially there's dry mouth. So if you notice like dry skin, dry other parts that are happening, but if you have dry mouth, that's like a serious issue because in a dry mouth conditions, that's where bacteria and cavities thrive. That's where I see my patients go from, I had no cavities and I brushed 3 times a day, to I have now 20 cavities in 6 months, because those dry conditions are the perfect breeding ground for bacteria to continue to like spread across all the teeth. So the common things that we see during menopause, dry mouth for sure, gum disease and periodontitis, and this is the biggest thing. With gum disease, it's linked to stroke, diabetes, heart disease, Alzheimer's disease, dementia. So that's where we start to see bleeding gums. It's super duper important that you see your dentist that they're actually measuring the gums every time they go in. If you're just going in, they're just taking a quick look and saying everything is great, and we're not actually measuring the gums, those things happen on a microscopic level. So if your gum measurements can go from like a healthy pocket being 1 to 3 millimeters to 4 to 6 millimeters, that's a lot of advanced bone. And so when that happens, those bad bacteria start to really help to break down the bone, and that's not really the first thing. You get your gums to reattach to your teeth, but once you lose the bone, you lose the bone. So it's super duper important that we're staying on top of that. Some of my patients see burning mouth syndrome, so their mouth is constantly burning, it alters that taste of like smell and taste for them. They have a metallic taste. Those are all early signs for you to be sure that you're actually talking and having a conversation with your dentist to make sure your mouth is healthy. So big warning signs to watch out for: bleeding gums, persistent bad breath, or bad taste in your mouth, and that's not going away. Like you try to tongue scraper, you've been brushing constantly, you're flossing. Flossing also, everyone needs to do it, but it's the #1 thing that's going to help you do that and to stay healthy. Any pain or sensitivity whenever you're eating or drinking that's persistent, or if you start to see that you feel like your teeth are getting longer and that you're having more gummy smile, that's usually a sign of recession happening. So also I tend to see with patients like there's changes in how their teeth come together, how they're biting, or they're having difficulty swallowing or chewing just due to the gum. So super important not to ignore those signs, because again, those small signs lead to bigger things in the life. Lastly, just keeping on top of your dental care routine, brushing twice a day, flossing every single day. Flossing is not replaced by water flossers, so try to, if you're not going to floss every single day, then try to do, or like floss in the morning and use your water flosser at night. It doesn't replace it, because I kind of think of it like a muddy car. If you're just like using your garden hose to clean it, it's not going to take anything on there. You need to actually go in there and physically floss down below the gums. Staying hydrated, especially if you feel like you have dry mouth, biotin or different supplements can help with that to help keep your saliva going. Because again, you want that good saliva to help prevent bacteria from sticking on your teeth and causing a ton of cavities. Lastly, avoiding like tobacco, limiting your alcohol, alcohol-free mouthwashes, super great. If you're using something that's like burning everything, try to move away from that, because it's just drying out your mouth even more. And sugar-free gum that uses like xylitol, anything with xylitol. I think Trident is actually one of the ones that has the biggest amount in there. Chewing that's going to help to reduce your risk of cavities. And again, go to your dentist every 6 months. Increasing calcium and vitamin D intake, like they were saying before, and fluoride treatments are super duper important during this time. I think that's everything.
What are your thoughts on the oil pulling and the tongue scraping?
Tongue scraping is great. It helps to remove any bad bacteria that cause bad breath. I personally have not seen any benefits to oil pulling. I think that
To what?
to oil pulling, because it's hopefully meant to prevent cavities and everything, but I have not seen that.
Is it, can you just think of it as like an alternative to mouthwash?
You can think of it as an alternative to mouthwash.
It's
No harm,
Okay.
but yes, it's not preventing or repairing. There's a rumor that like it repairs cavities. I have not seen it.
Okay. But I'm not doing any damage.
No, no damage.
So something I didn't know until probably like 6 months ago, and I feel a lot of people probably don't know this, and you tell me if I'm wrong, is I used to brush and then immediately mouthwash afterwards, and my dentist was like, no, you
Give it a
need to
little bit
keep
of a-
them because it kills your enamel.
Exactly. So
And I did not
when-
know that.
Yes, when we're brushing, it's abrasive, so
Yeah.
we're removing basically a layer of plaque and bacteria that's built up over the day. So when we brush everything off and then we're using mouthwash, it can be really abrasive to the teeth and cause it to dry out a little bit because your tubules that are lined with
Yep.
the tube.
I can't hear you.
those are exposed. So, sorry. So when you're brushing, you're removing a layer of enamel that's on there. So you've got, whenever we remove that, you have these open tubules that actually, that takes all of the good nutrients that we have in our mouth. So sometimes it just needs a little bit of time before we go directly to mouth washing because it just gives it a little bit of time to breathe and it prevents them from collapsing and drying out the tooth.
And then also for like the, I've gotten in the habit because of the cognitive support and all the links to Alzheimer's and dementia, is literally brush your teeth before you eat, before you drink your coffee. It should be the first thing you do.
Every day, yes, at least twice a day.
Yes.
Because again, as those bad bacteria build up, they become more and more aggressive. And so once they turn from an aerobic bacteria to an anaerobic bacteria, which means a bacteria that can limit that oxygen, those are more toxic. They can break down bones a lot more effectively. So we want to make sure we keep rid of those by making sure your gum depths are really healthy.
So could you do mouthwash first, or the oil pulling first, and then brush your teeth later?
Yes.
How long in between
30
after
minutes.
brushing?
That's ideal.
I do just wanna say that my 103-year-old mother, I firmly believe, died from, not having her teeth brushed for the last 6 weeks during COVID when I couldn't get there to see her. And she had no mouth care. And when I did finally see her, her teeth were black, all in between. I blessed her teeth, it was awful. And she got renal failure and died.
Yeah, and it's definitely.
She outlived
a link.
everything.
And it's a link that a lot of, it goes unnoticed and undocumented, and I think that it's just really important for it to be at the forefront, that we're actually recognizing how much it affects our whole body. Thanks for being part of it.
You're welcome, and I'm sorry, and I know that way, I know there's a lot of questions. Hopefully y'all feel like you got all your answers. If you didn't, contact them separately. I will give you all of their contact information. You're welcome.